Practicing dermatologist in Vashi and Navi Mumbai, Airoli. Because the CV slide is not available, I would like to
Yeah,
introduce
please
my.
introduce yourself,
Yeah.
Doctor. Thank you.
So I have done my post graduation from Goa Medical College, and I have been working with Disha Skin and Laser Institute for last 8 years, where I was the chief tutor for aesthetic fellowship courses. I have written one chapter in IDVL dermatology textbook on aesthetics, and currently I am founder of a clinic called Roshali Skin Clinic in Airoli, and I am the chief consultant at Dr. Udare Sparkle Clinic in Vashi. So, yeah, today's
Please start, Doctor, with your
yeah.
presentation.
So today's topic is very interesting. First of all, I would like to thank FADS for inviting me as a speaker. It would have been great if we had little more audience, but let's start on time. Innovations in dermatology, emerging technologies and trends. So let's talk about biostimulator. It is going to be 2025 is going to be a year of biostimulator. First, let's understand what and where exactly we are expecting biostimulator to work. So for that, we should have little bit of idea where what is happening with aging skin. So there is deficiency of cell regeneration, where the derm is assumed relatively acellular and avascular nature. There is thinning of dermal thickness, which is evident by decrease in the fibers of collagen, elastin, fundamental substances, and HA. Remaining collagen fibers are disorganized, as you can see in the image, and apparently they are thinner and more granular. These events led to replacement of type 1 collagen by type 3 collagen. So all the newer anti-aging treatments are being targeted to form more type 1 and type 2 collagen than type 3 collagen. Also, there are these extrinsic changes which attributes to aging, that is caused by chronic exposure to radiation, sun, and cigarette smoking. Now, as we grow beyond 30 years, the density of our collagen and elastin starts to deplete. Now, how exactly do we expect biostimulator to work? The inflammatory reaction after the injections of collagen biostimulator initiates the deposition of type 3 collagen fiber around the microspheres of the material, followed by fibroblastic tissue response and peripheral type 1 collagen deposition. This mechanism continues for weeks and until there is a remodeling of type 3 collagen and there is predominance of type 1 collagen. So have suggested that biostimulators can increase up to 30% of type 1 collagen. Now there are different types of biostimulator. So they are basically divided into hyaluronic. Good morning. So they are basically classified as hyaluronic acid base and non-hyaluronic acid base. In non-hyaluronic acid, according to the biostimulator collagen stimulation potential, they are classified as PCL, PLLA, calcium hydroxyapatite, and polynucleotide. Now, what is HA-based biostimulator? They provide more tissue hydration with some aspect of collagen stimulation. We don't expect too much of collagen stimulation. Whereas in non-HA based, we don't have so much of hydration effect. Now, what to expect when we are counseling a patient for injections of biostimulator? So, it will stimulate collagen, it will reduce fine lines and wrinkles, it will improve skin elasticity. The results are long lasting and they are minimally invasive treatment. Problem with Indian scenario is whenever you counsel them for fillers, first is the cost, second is they feel little scared or they are more skeptical about being a very invasive procedure. Every time you counsel and take consent for any vascular post complication, they go on their back foot. So biostimulator would be a really great option for those patients. Now these are the things which are available in India currently. Profilo, Restylane, Vital and Volite. Though all three are HA based biostimulator, we are seeing good result with that, but we are hoping as soon as the newer products are launched in India, we'll be more into biostimulator. Profilo, it's a dermal hydration with moderate stimulation of fibroblasts and collagen production. It is a NHYCO technology. 2 sessions are done 1 month apart. Many of us are doing Profilo in their practice with good result. Vital and Volite was a thing of 2020 to 2023. We have done many patients. Only problem is it is very difficult to show patient a very significant change because Indians in general don't have very dry skin, especially from the area where I belong to, Mumbai. So it is mainly on the oily side. So for them, it shows good result but not very promising. So we are expecting Sculptra and other products to launch soon. Dermal hydration with weak stimulation of fibroblast. It's made with Nasha technology and 2 sessions 4 months apart. Volite again by Juvederm is good for dermal hydration, but it has little weak stimulation for fibroblasts. Vycross technology 3 sessions 016 apart. Now, newer innovation, Sculptra, 2025 is the supposed launch date in India, a top tier biostimulator. It is made from polyl lactic acid. It is FDA approved injectable treatment for stimulating collagen, improves skin quality and addressing deep wrinkle and loss. It works gradually over 3 to 6 months, promotes natural tissue regeneration, ideal for mature patient, and it enhances facial harmony and skin texture, which lasts up to 24 months as opposed to other HA-based biostimulator. Redisis is a dual action derma filler. It is made up of carboxymethyl cellulose and which initially volumize the skin, and whereas the calcium hydroxyapatite microspore, it stimulates collagen production and enhance tissue regeneration. So it's a win-win situation. Elance is another collagen stimulator filler for immediate and long-lasting result. It consists of PCL and carboxymethyl cellulose. So CMC will offer immediate volumization, whereas PCL will stimulate new collagen. Now these are the polynucleotides. Nucleophil is an injectable skin treatment that uses a polynucleotide to hydrate, firm and contour the skin. So these are the newer things which are still under quite of studies going on for this particular polynucleotides. They are made from salmon DNA and are designed to rejuvenate the skin. They stimulate fibroblasts and collagen. They are more of a natural product compared to the regular biostimulator. Polynucleotide can be used as the first treatment to prepare the skin for further treatments and procedure. Now for Indian skin, if we look, there is very less of volume loss as the patient is aging. So all the treatments available which are filler are making patient look more puffy, more sagging of the skin is happening. So something like biostimulator will definitely be an innovation, and where we can counsel the patient how the aging is damaging their dermis and the collagen. So building up the dermis will give them a better look than just filling with 10 cc's of fillers. Now what is new and in toxins? These are the various toxins of which Botox and Despot is being extensively used in India, whereas Xeomin and Daxxify is still not available. These all are botulinum toxin A, so they have almost same result lasting for 4 to 6 months. Newer toxin in pipeline are Bonte. This is a botulinum toxin E, so it is made up of a different toxin E by Allergan. It is in its phase 3 trial. Results of this is novel neurotoxin serotype E characterized by rapid onset, which is as early as 8 hours after administration with short duration, that is 2 to 3 weeks it will last. Rela botulinum toxin A, it is going to be launched by Galderma. Relfides is the first and the only ready-to-use liquid modulator, so we don't have to reconstitute it. It will be named as Relfides. It is with Pearl technology. It is designed to deliver a highly active, innovative, complex-free molecule with up to 39% of patients seeing effect from day 1 and 75% of maintaining up to 6 months. It's optimizing for simple volumetric doses without reconstitution. So maybe it will be available in different doses and different units to increase ease and help endure consistent dose volume every time. Letibotulinum toxin by Hugel Aesthetic is also in pipeline. So with several new neuromodulators on horizon, predict that within a few years, patient wanting toxin treatment will have a full menu of option as we have in filler and injectors. So it is, as said by Dr. Varshil, it is an exciting time. We are beginning to customize toxin therapy beyond the well-established changes in the dosage and dilution. So we will be offering them a buffet like how we are offering them for fillers. What are the newer devices which are starting to trend on social media? Energet is one such device where it is a needle-free system that uses a high-pressure jet to release therapeutic solution in the dermis with minimal epidermal damage. It creates a 3D blast of tissue material that stimulates natural and neocollagenosis and neoelastinosis. So this is the machine. It is an innovative approach, deliver exceptional clinical, faster recovery. It is indicated to be used with HA to treat post-acne scar, keloid and hypertrophic scar. Elcor is another machine. It is more like a MNRF machine, but here the needles are hollow and they remove microcores of the skin, resulting an improved appearance of wrinkle without evidence of scarring. So it is how it is different. In MNRF, we are just temporarily displacing the tissue, whereas with Elcor, it is the first device to actually remove the skin. And as there is no heat used in this procedure, so there is no thermal damage. Now, what is the current trend in Indian practice? We all are going through this. Social media and marketing have more of an influence over the customer than, can I go? Just two more slides. Yeah. So social media has more of an influence over a customer than evidence-based research trial. So there are times we are trying to tell the patient, no, this is not right. But the trend is such that if it is said on the Instagram, if it is told by some influencer, patients tend to believe it over their doctor. So sometimes we have to give away, sometimes we have to be very stern at our position. So it's a doctor's call. Thank you all. So I am Dr. Rushali. Do visit Navi Mumbai for Coldplay concert. Thank you.
Thank you, Vrishali.
Thank you so much, and I would request one of the chairperson to please come forward to felicitate Dr. Vrishali. Ladies and gentlemen, please put your hands together as we felicitate Dr. Vrishali. Now we are all set to welcome our next speaker of the day, and for this I would request one of the speaker to please introduce Dr. Smriti Shrestha. I would request one of the chairperson to please introduce Dr. Smriti Shrestha.
Yeah, good morning. So now the next speaker for today's morning talk is Dr. Smriti Shrestha for her talk on from GFC to exosomes to PDRN to nanofate. She's a very renowned practicing aesthetic medicine in Nepal.
Dr. Smriti is a very, very renowned figure, and she's
Thank
there
you, sir.
in FADS right from day one, ever since we started this. And she's a wonderful doctor, wonderful plastic surgeon from Nepal. She's, people look forward for her techniques, for her innovations, what all she's doing with fat grafting, be it fillers, Botox, so on and so forth, never-ending list. So welcome, Dr. Smriti, please, for your talk.
Thank you, sir. Thank you for the warm introduction. Hello, everyone. I'm Dr. Smriti Shrestha. I'm a dermatologist and a hair transplant surgeon from Nepal. Today, I'll be talking briefly about my experience in fat grafting so far. As we know, fat grafting is the technique of removing fat from body reserves and placing them in area of need, such as face and other areas. I will be exclusively talking about fat grafting on the face. In 2013, there was a revolution in fat grafting where Dr. Tonard introduced a type of fat called nanofat, which is now popular for rejuvenation purposes. And why we are so bothered about and interested about adipose tissue is because adipose tissue contains a lot of things, including pre-adipocytes, cytokines, growth factors, lots of growth factors with healing properties as well as regenerating properties. Pre-adipocytes are especially important because these can survive in minimal trauma, they need minimum nutrition, and they can also survive and flourish in hypoxic environment, as well as these are the ones that have pluripotent potential compared to mature adipocytes. So it's the nanofat that contains these pre-adipocytes. Besides nanofat, there is another term called SVF, which is also equally being studied recently. So fat grafting on the face, the most important thing to understand with fat grafting, unlike fillers, is the regenerative cells require optimization of the environment. So what does it mean? It means that when you do fat grafting, you have to place it in areas where there are cells. I'm sorry, there's interruption. Okay, let me continue. There are 3 steps of fat grafting: harvesting, processing, and placing the fat in areas of need. So for harvesting, generally the standard dictum right now is you should use microcannula that are generally around 2.5 millimeter in size with blunt tip, and in the side there should be at least 3 micro holes which are at least 1 millimeter in size, and they should be sharp so that there's no direct trauma, but it also is able to extract the fat. And the video shows, the first video showed the microadits. Let me go back. Okay, the first video showed the microadit creation. I usually like the lower abdomen. People also extract fat from other areas in the body. There was a school of thought that said that fat in the lower abdomen and medial thighs were the best for harvesting purposes, but now that dictum is also nullified because fat from everywhere now is considered good for harvesting as well as with stem cell purpose. So this is a very old video of mine that was in 2017 from our hospital where I used to work. This is how the fat is extracted. I wish I could play this faster. Once the harvesting is done, the most difficult or the arduous task should be the processing of the fat. But nowadays there are pure fat devices that are able to process the fat by itself. You don't have to do mechanical processing anymore. So there's also another school of thought that once you take the fat out, centrifugation process, some people like centrifugation, some people don't. Why? Because during centrifugation, the mature adipocytes are lost or disintegrated, while the pre-adipocytes and the nanofats are retained. So I prefer centrifugation, and I also prefer centrifugation because the fat is divided into the aspirate, the lipoaspirate that we take out is divided into 3 different segments where the blood lies at the end, rearmost end, while the oil goes on top, and the central part, only 1/3 of the aspirate is pure fat, which should again be converted into nanofat. I don't know why the videos are not playing. Could you please play the videos, please? I'm so sorry, the videos, I don't think it's being supported right now. Okay, so there was a short clip about how the fat was being processed. They're usually fem-to-fem connectors, which are of different sizes that are available. The connector could be anywhere between 2.4 millimeter to 0.4 millimeter in size, and depending on that connector size, the fat gradually transfers into microfat, nanofat, and SVF. This is a picture of a microfat. I had video of nanofat, which unfortunately is not being played. And to inject the fat, it is more difficult than fillers because fillers are can be placed anywhere. They do not require any vascular supply, but fat needs vascular supply. So I usually like the technique of layering. The fat are divided into small micro droplets where they can be placed into different segments. And initially it was believed that half of the fat would not survive. That's why there was a trend of overfilling. So right now, the trend of overfilling is not there, because if at all the fat will survive, then the patient will not look what you desire them to look like. So the final results of fat grafting of the face usually comes at the end of 3 months. Normally what happens is when you put the fat, it leads to neovascularization. There's a period of ischemia in the first 4 days, and then there's a period of neovascularization that takes place over the next 3 months, and it's the 3 months that the final results will settle. So that usually lasts for anywhere between 1 to 10 years, depending on different kinds of patients. In my experience, the fat lasts better in younger people with more tissue volume, like people who have better volume on their faces. This is the article that I talked about in the beginning. This is by Dr. Tonard, and he revolutionized fat grafting by introducing nanofat, which has no intact adipocyte, but lots of pre-adipocytes as well as stem cells, adipocyte-derived stem cells. Well, this one thankfully is playing, but this is a very old kind of a connector. Nowadays there are better connectors available which have lure lock in them so that the fat does not spill, or it's easy to handle. So about how much fat to inject at a time, it's usually less than 0.3 ml at a time, because like fat has 3 layers. One is the outermost zone, third is the necrotic zone. So larger the fat particle, more the necrosis. So you have to have small pellets, and there should always be tissue in between so that there is blood flow, and that blood flow generally is the one that gives the vascular supply and as well as nutrient to the fat that survives. So from that aspect, I've done a talk in IMCAS 2 years back where I talked about serial fat grafting. So now I believe in, when you're doing volumization, when you're not talking about regeneration, but when you're dealing with volumization, I don't think we should promise for optimal outcome by just doing one session. So I do believe in serious fat grafting, because once the first fat session is done, it produces a scaffold, and this tissue scaffold acts like it's like a nutrient for the next session, and that led to survival of the fat more compared to doing just one session, especially for volumetric purposes. This is one of my recent cases where I have done the tear trough, and I love fat. Fat is more easier to put in tear trough, and it leaves more smooth contour, but the question again remains how much of it survives, because tear trough generally has, especially in this guy, it's very hollow. So in these kind of hollow cases, you may need up to 2 sessions for the final results. I had a video of the fat being done, but then I don't think any of these videos are going to be played. I'm really sorry for that. And this is another guy. As you can see, I've done very minimal in this case, and his fat survived around 50% at the end of 3 months. So we again have to go for a second session after 6 months gap. I usually take 6 months gap if I'm looking for a second session. And this is another lady who already had good volume, but then she had certain regenerative wishes. So for that purpose, we did the micro and nanofat both. Micro is placed deep under, while my nanofat is placed superficially in the dermis. And I was quite happy and surprised that at the end of 3 months, her melasma had significantly improved, and her texture is also better. And this is another lady. Again, I had a video. This is one of the, I think I put around 25 ml of fat everywhere on her face, from her sides of the temples to under eyes to laugh lines to her sides, subzygoma region. So she wanted a Korean kind of a face. So she's still with me in follow-up, and it's been almost 2 years now, and her fat has retained very well. In her case, I'd shared it with my friends as well, that I did her full face fat grafting because she had done some fat grafting somewhere else, only under the eyes, and it had beautifully retained even 2 years later. So I was encouraged to do the full face in first session, and for her, I had only done one session 2 years back. Now she wanted second session around a month back, and that was not in the areas that are already placed. She's one of the good candidates where the fat has survived very well. So in my experience, fat survives better in people with, chubby volumetric faces. That's probably also because they have good tissue supply, and eventually it's all about vascularization. So they have good blood supply as well as tissue scaffold that helps the fat retain longer. This another case, this was very difficult. This I have shared in the past as well. He had childhood morphea, and I had done hair transplant as well as fat grafting. In his case, the fat did not survive that well. He was, I think, visited many centers for fillers and all, but then he chose fat grafting. I had already counseled. I did 2 sessions of microneedling. I did PRP, before the fat grafting. I did everything before the fat grafting. I do have photos of his hair transplant and the remaining, the kind of growth that we saw after hair transplant, which is, to me, it was satisfactory, but to the patient, I think with 1 session, it was not as satisfying as I would have otherwise thought. So this is another lady. Looking at the 2 cases, they both have similar kind of depression, but the second lady's results retained quite long. She came to me 2.5 years later. Her results were retained. This is another case of just fat grafting. So nowadays, fat grafting can be added in combination with other treatments as well. So I'm doing nanofat on the hair, as well as that was a video of me doing lipectomy of the axilla for axillary hyperhidrosis. On the hair, nanofat stays better because of the adipocyte hair crosstalk. There's this crosstalk that happens between adipocytes and the hair, and these mature adipocyte cycle along with the telogen and anagen phases of the hair, and hence they lead to good regeneration, especially in female pattern hair loss. And usually the results last for up to 1 year. And this is another case of there are just 2 slides on exosome. Unfortunately, both the videos are not playing. I've seen good results with exosomes. I'll not talk further on exosomes right now because of the time constraint. Okay, so finally, I think the era has begun for nanofat and rejuvenation rather than for microfat or the structural changes, because structural fat grafting is more done in combination with facelift and other procedures, while nanofat can be done single-handedly for rejuvenation, skin texture, as well as hair changes. And these are some of the articles. And thank you, FADS, for inviting me. This is I think this is my picture from 2 years back from Goa. Thank you so much.
Thank you very much, Smriti. And now,
I would request ma'am to please come right at the center of the stage, and I would request one of the chairperson to please felicitate Ladies and gentlemen, please put your hands together as we are felicitating Dr. Smriti. Now, moving forward towards our next speaker of the day, now I would like to invite here on the stage Dr. Patrick Tracy, and for this I would request one of the chairperson to please introduce Dr. Patrick Tracy.
Thanks for that. All good? Hi. So, Dr. Patrick has a best-selling author of a globally renowned leader in aesthetic medicine, known for his pioneering contribution and numerous accolades. He serves as a visiting professor of dermatology at ISRA University in Pakistan and has received fellowship in cosmetic surgery and medicine from Australian College. Additionally, he holds a laureate in aesthetic medicine from Azerbaijan College. In 2024, he was honored with the Man of the Year award in Ireland and named the top aesthetic practitioner in the world at the My Face, My Body Global Awards in Las Vegas 2019. He has been recognized as Doctor of the Year in UK and Ireland on multiple occasions and in recent years. His as Aylesbury Clinic has been awarded top clinic in Ireland 5 times in the last 7 years. Dr. Tracy's innovative research has led significant advancements in the patient safety, including development of protocols for use of hyaluronidase in aesthetic medicine. He has received international recognition for his work in stem cells, PRP, growth signaling factors, and skin rejuvenation treatment of necrosis following vascular occlusions.
Well, thank you very much for that wonderful introduction. This lecture is actually closer to 30 minutes than 10 minutes, if you bear with me. I suppose when we started originally, there was no such thing as aesthetic medicine. And I'm talking back in 1997 when we wrote the protocols for chronic migraine that are used worldwide now. And I suppose with HIV and all the different global pandemics that we sort of lived through. So in the beginning, we started off with Botox, and I'll quickly go through this. You sort of know the protocols now, but people forget that when the problem started with Botox originally, we had to come up with the answers. There was no conferences like there is now where young doctors can go and learn the sort of way. So this is the first eyelid ptosis that was presented to me in 1998. And she'd been told by a colleague of mine that this was probably going to be permanent. And we didn't have solutions then. Believe it or not, the use of iopidine, phenylephrine, that came later, but it was people like myself that had to work out what you do with it. Now, at the time, this was when Botox was starting in Ireland, a lot of doctors were afraid of it. And some of my colleagues in plastic surgery at the time had written and said that this will cause a lot of problems. So Andreas McEntee, who was editor of the Irish Medical Times, told me at that stage, could you write some articles on Botox just to educate our doctors? And one of the ones I had said was, this will be seen by future generations the same way as antibiotics are, that it can be used in the treatment of chronic pain. And that video that's shown at the same time is the introduction of Botox to Ireland back, well, now 25 years ago, something like that. So with ptosis of the upper eyelid, I'll quickly run through it. We now use iopidine, as you can see. You can also use phenylephrine. Everybody has it in their clinic. It's very easy to use. We use it for looking in the back of eyes. The only problem is that it causes dilated pupil. But believe it or not, one of my first reasons for using it was because it was treating blepharospasm, and that patient came in to me, and I took a chance to an extent to see whether if we injected the patient just along the pretarsal area, and 1 week later she was like that. So a lot of the early toxin problems, I sort of treated like that, by just Botox caused the problem and let Botox solve the problem. So that was back in 2003, and then we started getting brow ptosis, some of them that couldn't be corrected. This poor patient presented to me. She was quite distressed over that, and I had to put in a thread in order to restore her. Then we started seeing the problems with derma fillers. The original problems were just infections. They were easy enough to treat. And this is actually in later life with some of the products that were mentioned on the stage this morning. I'll not say which. And most of the problems could be treated just with augmentin. Now, some of the later problems that appear 3 months afterwards, they all are sterile abscesses. And, you know, a colleague of ours in Holland, Tom de Cattes, has shown that some of them are very unusual infections. Restylane came on board. I used Restylane first at the end of the last century, and we thought that sort of this would be the answer, particularly because America was using collagen, and some of the first problems were quite simple. That was just an allergic reaction, give the patient some dexamethasone, and they cleared up. I know Sculptra is only coming to India, but in the early stages, we were only mixing 3 mils with it, which I thought was wrong. Now, I had done a lot of work on HIV patients, HIV lipodystrophy. I treated 45 at least at that time, and I'd written up some papers. And one of the problems we had with Sculptra was that they needed 5 treatments with about 70 injections each treatment, and the risk of a needle stick was quite high from patients when there was no cure. Well, antiretroviral drugs were just starting, and we couldn't really trust who the patients were. We were getting them from South America, we were getting them from Italy, we were getting them from Spain, and they could be anybody. Unless you ask for their passport, they could be bringing you in somebody's report, which wasn't theirs, that shows that their CD4 levels and the fact that the virus wasn't identifiable. But I mean, there could be anybody. So I was very uncomfortable using Sculptra with these patients. So we switched over to Bioalchemid, which caused its own problems. So this was the period of HIV, and Sculptra at that time was causing these problems of sort of granulomas. And at the time, I thought it's not diluted, because when you were injecting it, it was sticking in the syringe all the time. So one of the patients, we took out the nodules, and there were crystals of Sculptra, of polylactic acid. And don't forget, polylactic acid is what we use in the plastic tumblers that we were using last night. So in terms of this, we had decided to put 8 mils in the mixture of sterile water, 5 mils of sterile water, and 5 mils of lignocaine with adrenaline. So HIV was bad in that period, and we switched over to bioalchemid. Bioalchemid was wonderful at the time. It gave a permanent solution. That was the first patient I treated in the United States, 2004. Believe it or not, he got married after that and went on a world cruise. And I wrote some of the first papers in terms of using bioalchemid for all these HIV patients. The problem was that 10 years later, these things kicked off, often because dentists had given an injection that went into it, sometimes people lying on the sun. And I was very lucky because I had used a method of introducing bioalchemid where I used like 1 needle, and we were putting 15, 20 mils in some of these patients' faces. But I mean, they all, again, formed these sterile abscesses. The ones that I treated, it was very easy to remove this. I started getting patients from all over the world where people had injected them in different ways, and they were very hard to deal with. This was back in 2003. Bono gave Alex Ticatino the United Nations Humanitarian Award for his work in Africa. And one of the things that I noticed talking to Alex was that he didn't have any of these patients with lipoatrophy. Now, there was 2 theories at the time. One was that people were living longer, and as a consequence, they were developing this, which didn't really make sense to me. Or the other thing was obviously that the drugs were causing the problem. So I favored the drugs were causing the problem, and I'd contacted Alex at the time in Africa, and I noticed that his patients were just dying, whereas ours were living. So they were living because of the drugs. And it took some years later where it showed that actually it was the drugs that was causing the problem. So the new antiretroviral drugs don't tend to cause this problem. So the problems with bioalchemid then were inflammation, accumulation, encapsulation, migration, and there were big problems, so it was pulled off the market. In 2004 in Moscow, I was invited to speak on stem cells, and while I was there, I was given a lot of patients with this Italian product from Brindisi, Bio in Blue, which was similar to bioalchemid. So we took a lot of these patients and we just had to cut out the problem, and that was some papers that I'd written at the time regarding Bio in Blue. So that's still, believe it or not, 20 years ago. Then we started seeing problems with sub-Q, and in terms of sub-Q, the patients ended up with faces like that, and that's an MRI showing that these had kicked off. Now, sub-Q was made by QMed, who made Wrestling, that was sold later to Galderma. So we had a situation where in the United States, where we considered they were quite behind us at the time, and possibly in some of the things still are, but that's because of the FDA had blocked things. They had only 4 products. We had 168. So I felt very, I suppose, troubled the fact that our patients were being used as guinea pigs by a lot of the companies, whereas, believe it or not, even though most of the products we had in Britain and Ireland and Europe were taken off the market in later years, we ended up with the same ones that they did in the United States. So we really need an equivalent in Europe of an FDA. We're sort of working on it. This was an interesting thing. This patient here, I was testing interlesional steroids. I was testing 5-SU, and the bottom line on the left side of the picture rather than the patient, that was interlesional steroids. So we started using interlesional steroids. And then we started getting a lot of what was potentially biofilm. Biofilm came as a fashion and went again. Anyway, at the time I had said, what is happening is that some products are forming collagen around themselves. So if you're going to treat them, you need to treat them 3 different ways. Mix it up or do it at the same time. The collagen around it then form bacteria, and we're still 20 years later in that situation. So I said to use a mixture of hyaluronidase, intralesional steroids. I use depomedrone. I have nothing against Kenalog, and antibiotics. And I suppose that was the type of patients that we were getting through, and quite a lot of them. Then I had this patient here. She was the wife of a colleague of mine in Miami, and she had been treated with a silicone tap injection, and he had sent me some similar patients, 2 or 3, and we referred her, or actually she referred herself, into a colleague of ours in Los Angeles, facial cranial unit, and part of her back was taken to form her forehead, and this was her in later life. And when I was chairman of the Royal Society of Medicine, we presented 2 of these cases and let the patients speak for themselves in terms of hemi-autologous facial transplants. So the one on the left had necrotizing fasciolitis with a hemifacial transplant, and the one on the right was Carl, who did the introduction of one of my books also. So then, I suppose, when wrestling came originally, I had proposed that we should be using hyalase, and I sort of ventured into that yesterday slightly, that sort of I was advocating the use of a reversal agent, but believe it or not, the companies didn't seem that interested, and then mad cow disease came, and believe it or not, our attitude in medicine has often been dictated by what's happening in the world. If we take a simple thing like wars, we have a war against cancer. So if you take the Battle of Shiloh in 1860, we were killing people with swords. And at the same time, we were cutting out cancer with surgical instruments. Then, the First World War, Germany introduced chemical warfare with gas. And at the same time, Paul Schilling used chemotherapy against cancer. The Second World War, we had nuclear bombs. And we also used the XRT just 2 years later, 1947. And then we had, I suppose, the original biologics used as warfare by Saddam, and we had grass versus host disease. And then in a later conflict in Iraq, we had profiling that an Iranian or certainly an Iraqi shepherd could walk by a bomb, but when an American soldier walked by it, it blew up. And that type of profiling we now use in, I suppose, cancer treatment as well. Now, I only mention this because aesthetic medicine seems to run along the course of the recent pandemics, mad cow disease, HIV, and COVID. So it's how we react. When mad cow disease kicked off, don't forget collagen was coming from the hoof of cattle in Texas and also from rooster combs. So this made our American colleagues think, oh my God, we could be transmitting these diseases to our patients. So it took that to make, I suppose, them switch over to hyaluronic acid. But in the period prior to that, we had a lot of American patients coming to Ireland for treatment. Seafield Conference 2007, that was for Radiesse. I said Radiesse shouldn't be injected in the sort of perioral commissure area, that it is problematic and probably shouldn't be used in vascular areas as well. And then we had Pete Burns, who's died since. Somebody injected it into his lips. Well, I know who injected it into his lips, and that case was settled. And this is the sort of problems that Radiesse caused. And when it caused it, unfortunately, it was in the hands of God. There was no sort of reversal agent. And we got a lot of those in that period of Radiesse. I got them from China. I got them from the United States. And Then we started seeing problems with lips. That type of lip there, that was Q8, was just a massive bruise. But at the time, I started seeing a lot of those. That's a patient came in to me, and a beautician had injected her lips. And if you look at that, you would think, oh my God, that beautician is terrible. But it's not the beautician's fault. That patient had a C1 esterase problem, and that was angioneurotic edema. I gave her some adrenaline, and 20 minutes later, she was like that. So before we're often critical of our colleagues, particularly the ones who aren't of the same educational level as ourselves, maybe it's time to just stand back and don't be blinded. If you were an ER doctor, you wouldn't pass moral. So as a consequence, consider what is actually happening here. So we started getting a lot of complications, and that was an email, I'll not go into it, that had come from one of the companies saying, we don't really need hyaluronidase, what are you talking about? So this is some of the patients that I used hyaluronidase on back 22 years ago. So hyaluronidase, this is the one we get, 1500. It comes from stonefish, it comes from vipers, it comes from bees, and what does it do? It was originally used in medicine for the absorption of fluids. If you're using something like Botox for hyperhidrosis, you can mix it, it'll work better. It's used after heart attacks, and that was, I suppose, Michael was sent to me many years ago because they wanted to take hyaluronidase out of his face before he met the Queen, and he got shy, and in the end he went over and he didn't meet her, he just stayed in his hotel. So then we had predicted that you were going to start getting vascular occlusions. It had happened with other fillers, and that was an IMCAS lecture that I gave some years ago. There's no volume with it, but it's saying that you got to use high-level hyaluronidase. Anyway, I'll move on. These were the sort of problems that we started getting in, and again, I'd advocated the use of hyaluronidase, and in 2014, we convinced, I suppose, our American colleagues to put up their units from 150 to closer to 1,500. Then in Moscow, where they had advocated my units, and they actually called it the Tracy technique, and this was me being interviewed for television in Russia regarding the use of hyaluronidase back then. Then we started seeing, obviously, dermafiller blindness. I had advocated that we should use the supraorbital method rather than the retroorbital. I'd advocated the use of hyaluronidase, I suppose, all the way back then. And in more recent years, I suppose, I've been awarded in Abu Dhabi and in Pakistan also for introducing hyaluronidase to aesthetic medicine, or at least the protocols that we use today. And in terms of vascular occlusions and blindness, those were the early days when we were using the O2 hyperbaric chambers. It was an old one. We started seeing blindness. I showed this yesterday. One of our colleagues in London had caused blindness. And in terms of treating them, I was a lot of ones. I started writing papers on, I suppose, how to reverse facial artery occlusions back quite some time ago. And I've probably reversed, I don't know, maybe 100 vascular occlusions at this stage, and but most people know how to use it themselves. So that was all the way through there. I came up then with what's called the helper technique, and that was if the tissue is necrotic or going necrotic, that we could use PRP, mesenchymal stem cells, and red light to reverse these patients. This was a patient that had presented with vascular occlusion. When she got the reticular formation with hyperemia, the GP thought it was a bruise. They can look similar. Put her on one of the sort of agents for bruising at the time, and obviously things got worse. So she developed bullae. So then the GP thought she had an infection. And I mean, you could mistake that for an infection, but it's obviously skin that's becoming necrotic. So I seen that patient 7 days after it happened, and we introduced the use, I suppose, obviously of hyaluronidase, but we also give her some red light steroids. And it's an interesting case because if you look at it, the 7 growth factors, one of the things that's going to happen is you get vascular growth factor, so the patient's going to get very red. So don't worry about that. At least you're beginning to see epidermal tissue coming. So when the patient has enough epidermal tissue that they're not going to burn, you can use IPL. And when you use IPL, you'll get rid of the residual blood vessels. And then keep it sort of within your power that you don't get too excited. You're going to run for 150 days with this before you clear it. So then what you do, you have the rough skin, so you use CO2 and it'll form new skin. So you've got a situation where you've got necrosis that has been left to form a big scar, and what you do is you treat the necrosis by bringing growth factors through mesenchymal stem cells or PRP. You can apply those topically. It will heal. You'll see the sweat ducts. You'll see the hair follicle starting. You know you've epidermal tissue. And then don't put the IPL on too early or you'll burn the skin. So give them a period of probably 6 weeks. Start using IPL, 3 treatments. They'll come back with rough skin and then use CO2. So I won awards for that some years ago. And then that was some of the papers that I wrote up on it. Regarding dermal filler blindness, we gave a talk on that yesterday, so I can spin through that, so I'm not holding up the conference. And that's good. That was all part of the original talk. And that was some of the cases that were reversed by using the supraorbital method. And we lead in then to our colleague in Vietnam, who uses, I suppose, cannulation of the internal carotid artery, of the internal carotid artery to the central retinal artery. What have we got here? That's again a lot of cases that presented with complications. So I could stop at that or continue. That's another lecture in terms of delayed tissue nodules, whether they're inflammatory or infectious. Will I continue or go on? Yeah, you can. I'm going to continue, okay. So we're left with a situation where we're still getting nodules. And we're left with a situation, are these inflammatory or are they infectious? To be fair, they're probably both, and you should treat them as both. So in other words, if you're given steroids, you need to back it up with an antibiotic that things don't get worse. And for using antibiotics on their own, they probably aren't going to clear it. So we know that sort of these delayed tissue nodules appear about 4 to 6 weeks later, mostly 3 months later. And we have disagreement among our colleagues about how to treat them. Now, I've treated lots of these successfully, including when I go back to Ireland tomorrow. I've got 2 waiting on me again. So I had written protocols in the book in terms of the use of intralesional steroids mixed with hyaluronidase at the same time. The doses are there if you want to see them. And what I normally do is I take depamedrone, probably dilute it down to 10 or 25%, 50% max. If you start using higher doses of intralesional steroids, you're going to end up with lipoatrophy or dermal atrophy, and you don't want your cure to be worse than the disease. So that goes through how to use the hyaluronidase. I can skip through that. And then I have to surgically remove a lot of them. And the problems often exist also because if you're dealing with mid-cheek, it's on the bone, it's below the zygomatic muscle, so you've got to get the problem out underneath the zygomatic muscle without leaving the patient with a big scar. So I run through that. You can use a blind probe and do a washout. And I suppose when you're dealing with them, the zygomaticus major seems much bigger than it is in that picture. And that's just some case studies, and that's the patients talking regarding it. And this is an interesting case. During COVID, when we started getting a lot of nodules, they were unresponsive to everything, including interlesion steroids and hyaluronidase. I introduced methotrexate on a study of 23 patients, and they reversed. And now a lot of my colleagues, Hugh Cartier, Maria Landa, George Konopoulos, are using methotrexate also just for DTNs. And I've started to do that also. So it's interesting in terms of using, instead of steroids, methotrexate. Obviously, you have to monitor the patients with sort of the liver function test and that. And we're considering the use of dapsone, which has less sort of side effects. And that, in terms of infection, we know that there's a neutrophilic response. We know also that low molecular weight hyaluronic acid seems to be in the presence of local bacteria. The bacteria seem to grow on the inflammatory reaction they set up. What we've against it is the fact that whenever we do culture and sensitivity, we don't seem to be able to get anything. These respond to methotrexate, they respond to steroids, nothing grows on culture and sensitivity, and that's another lecture on its own that I'll not hold up the conference with. And that was, I suppose, during COVID, we started getting all these patients into us. And that's just the use of methotrexate. And that's polynucleotides. So I could end my lecture at that. I think I've been up here long enough, probably. Thank you.
Thank you, Dr. Patrick, for excellent presentation and wonderful photographs, pictures you have clicked. Thank you.
Ladies and gentlemen, now I would request our chairperson present here, Dr. Manjeet Singh. Sir, I would request you to please felicitate our other chairperson who are present here. So we are going to start the felicitation for Dr. Sandeep. Ladies and gentlemen, can we have a big round of applause as we are felicitating Dr. Sandeep? And now we are all set to felicitate Dr. Kailash. Thank you so much, chairpersons. Thank you. Now, moving forward, ladies and gentlemen, as we step into our next session, we have a recorded video lecture by Dr. Roya Zarmeer Zameen, and she is one of IMCA's speaker. She couldn't be here, unfortunately, but she has recorded a video for all of you. So everyone, please pay attention towards the AV.
Hello, my dear colleagues. I'm Dr. Roya Zarmeer Zameen. I'm a cosmetic dermatology expert and global trainer. I am truly honored that I can join the FADS Congress, this prestigious Congress, but I was very unfortunate that I wouldn't be able to be in person in beautiful New Delhi and meeting all my esteemed colleagues. I'm very honored that I'm joining this conference as IMCAS representative and faculty. And briefly, I'm going to explain about the IMCAS Academy and IMCAS Congresses. In this session, we are talking about the future of aesthetics. One of the key, important key in aesthetics, which is regenerative medicine. And I hope you enjoy this session with my brilliant colleagues. And we'll talk about all the regenerative medicine, different treatment, different product in this field. About IMCAS Academy, it's one and only platform which over 32,000 of physicians from all around the world are member of the academy. And this academy, over 12 years that they started their journey with over 9,000 videos, which is all exclusive. And almost every week there is a webinar from different colleagues and about different concepts. And also, most of the courses are CME accredited, and over 1,700 clinical cases through IMCAS Alert. I have to explain briefly about the IMCAS Alert, one of the unique platforms that all the physicians from all around the world, they can share their challenging cases or complications with the colleagues, and in a minute the colleagues answer and discuss all the treatment plans or protocols and everything. And this is free of charge. It's very important, and it's a platform for the safety of your practice and safety of your patients. And in CAS Academy, the concept of treatment. Hello again, everyone. I'm introduce myself again for those who just join us. I'm Dr. Roya Zarmazamin. I'm an aesthetic physician in Iran and Dubai, and global aesthetic trainer and ultrasound trainer, and very on and restore and medicine focus on restore the natural beauty. All the trends are overfilled or volumizing. It's going to be in the history, and so many people trying to reach and restore the natural beauty. It offers a more holistic long-term approach to achieving healthy, useful skin by stimulating the body's own regenerative process, ensuring the subtle, natural-looking result. This shift reflects the growing trend toward preventative aging rather than simply overfilled or addressing the sign of the aging. Let's briefly talk about collagen. Collagen, as you all know, is a main structural protein. There is many types of collagen, but the collagen is a stranded helix polymer that produced in extracellular matrix. Gram to gram, when you compare, collagen type 1 is stronger than steel. Function is provide to strength and support, compromise 80% of skin dry mass. Collagen type 3 is another major component of extracellular matrix, and the function is help keep collagen type 1 fibers organized. And collagen type 7 anchors the dermis to the epidermis. Collagen type 1 85 to 90% in normal skin, 15 to 20% in scar tissue. A bundle of thick fiber, closely packed, thick ultrastructure, and densely packed, and there are variation in diameters. Collagen type 3 distribution is 10 to 15% in normal skin, 80 to 85% in newly formed scar tissue organizing individual thin fibers. Their loose frameworks, thin, weakly birefringent, ultrastructure, loosely packed, and this is the difference between these two main types of collagen. When we talked about elastin fibril gives skin elasticity. It's referred to its name, allowing to stretch and bounce back. Elastic is a long-lasting protein which expands and contracts and present in the whole body and stabilizing collagen fiber, which is very important component in extracellular matrix. It can be broken with metalloproteinases in the body. When we talk about aging, we will see the sun exposure is one of the main environmental damage factor, which is a primary factor in collagen and elastin degradation. Collagen molecule atrophied, elastin fibers is going to be broken, and then with the atrophy of the same, different level, the aging sign appears. When we talk about this aging means decrease in number of fibroblasts as well as skin supporting proteins and polysaccharides. Biostimulatory product typically results in the foreign body reaction that produce the local fibroblast activation, collagenesis, elastogenesis, and the semi-permanent result over a year. Example is calcium hydroxyapatite, PLLA, PMMA, and PCL. We are going to talk briefly about this. There is so many brilliant publication about a biostimulatory product, about calcium hydroxyapatite, compare it with HA, compare with a volumizing effect versus biostimulatory effect of the calcium hydroxyapatite, and talking about mixing calcium hydroxyapatite with HA. There is so many publication for those of you that interested in reading. You already read it. Then you can reach me by my contact info. Calcium hydroxyapatite is a microsphere which is smooth and regular, and the size is 25 to 45 micron. If it's the irregular shape and rough, it result in foreign body reaction. If it's very smooth result and regular and spherical, it's a fibrous tissue with collagenesis. Calcium hydroxyapatite, we can use it as undiluted or diluted or very diluted one. And undiluted one produce collagen type 1 over 61% compared to HA. Elastin can be increased with undiluted calcium hydroxyapatite stimulation, and significantly stimulate stronger angiogenesis compared to HA. When we talked about hyperdiluted or diluted calcium hydroxyapatite, if we use a diluted 1-to-1, usually provide both volume and the stimulation and remodeling, and hyperdilution which is more than 1-to-1 dilution, it's more effective for biostimulatory, and the peak, the start is at 4 weeks after the treatment, and the peak is achieved in 7 to 9 months with producing collagen type 1 and gradually replace.
Thank you so much. And now we are going to proceed with the panel discussion. And for this, I would like to invite our moderator here on the stage, Dr. Bhavani. Can we have a big round of applause for Dr. Bhavani? Okay, so it's Bhavani. Apologies for that. Dr. Bhavani. Can we have a big round of applause for Dr. Bhavani? So, for this, I would like to also invite our panelists here, Dr. Smriti, Dr. Sadhna, Dr. Vrushali, Dr. Monica, and Dr. Chetna. Can we have a big round of applause for all the panelists? Our esteemed panelists are kindly requested to please get here on the stage and take your seat. Thank you so much. Dr. Bhavani will be taking over. Bhavani, sorry. Same pinch goes to both of us.
Hi, good morning, everyone. At the outset, I would like to thank Dr. Ramanjit, Dr. Rana, Dr. Jyotirmay, and the whole FADS committee for the invitation. I would invite other doctors also. Dr. Chetna, I think she was there, right? Dr. Manisha has not come? Where is the, how do I change the slide? The green. Dr. Manisha is not there. Monica? Yeah? So let's start with this topic of biostimulators. Now from the audience, I actually want to know that how many of you all are doing biostimulators? Yes, Dr. Kiran? Yeah, Dr. Ginny? Among the panelists, hi, good morning. Yes, among the panelists, I want to know who all are doing biostimulators. Wow, very good. So let us tell the audience what are these biostimulator injections. What are they? Oh, you want the mic? Yeah, I think they would require one more mic. It's not working. Yes, Dr. Chetna, we were missing you and we have not yet started. We were just waiting for you to come. Yes, so now we will start. Among the panelists now, Dr. Vrashali, yeah, would you be able to highlight on what are these biostimulator injections? What are they?
So basically, biostimulators, they are broadly classified as HA-based and non-HA based. Currently available in India, all of them are HA based. So we are mostly using Profilo, Vital, and Skin Booster. PRP is another naturally occurring biostimulator, which is the most used procedure in India. And all the non-HA based biostimulator are going to be introduced in 2025, hopefully in India. So I have not personally tried either the Sculptra or any Elance or any of those products, but we are very much used to using HA based biostimulator.
Yeah, so actually I want to know what are they? Why do we call it as biostimulators? Dr. Sadhna, yeah?
Because when we want to repair, when we want to work on a repair and regeneration,
Yeah.
we use biostimulator because they stimulate your own collagen, your own stem cells to reproduce and to neocollagenesis, regeneration. So the idea is when you start biostimulators early, you are delaying the need of other invasive anti-aging procedures like
Right.
facelift or any invasive procedure when you start biostimulators early in your patients.
Okay. So in short, these biostimulators, basically they help stimulate cells like fibroblasts, which produces more of collagen and elastin, and in turn it helps to slow down the aging process, right? But how do they differ from our normal dermal fillers? What is the difference between a biostimulator and a filler, Dr. Chetna?
So biostimulators, basically dermal filler. The concept is lifting and volumization, whereas biostimulator, we are talking about Profilo, Vital, Volite. They are deep hydration, collagen stimulation. They help in expressing CD4 markers in expression of TGF alpha and all, which helps in elastin and collagen formation. So we are not volumizing, we are not lifting, we are improving the quality of the skin.
Okay. So this is how it is.
It's also how they are made. In the sense, dermal filler make is more cross-linking,
Right.
and the percentage of HA is more. Whereas in boosters, HA, they are low cross-linking or non-cross-linking. HA percentage is can be, I mean, Profilo is the highest percentage of HA, but the make is different. The BDD is not there. So it is how they are made.
So I think then the difference between, yeah, Dr. Vrishali.
So mainly we are targeting to produce type 1 collagen.
Yeah.
That is the main purpose of a biostimulator, whereas in HA that is not the target. It is more of a hydration. So
Okay.
here we want to reverse from collagen 3 to collagen 1. That is the main purpose of injecting a biostimulator.
Yeah, doctor.
Yes, we've also been using lots of biostimulators in Nepal, especially I'm in love with Profilo, the kind of lifting that it can give slowly, especially in younger people. I think biostimulators are more for, it's also for older people, but these can be started earlier than fillers, even in younger generation.
Okay. So the main difference between the filler and the biostimulator is fillers always gives more of volume and hydration, and biostimulators will actually stimulate your collagen. So it will help to delay the aging process, right? That's okay.
Also the placement, like fillers, you will place it on periosteum or supraperiosteal, and boosters, you will place it in mid-dermis.
Okay.
Or
Yeah. Or in the dermal, yeah,
or
basically the
I mean dermis,
dermal layer.
in the dermal layer, yeah, superficial dermal layer or a
Dr. Shrestha, can you tell me what are the different kind of biostimulators now available all over and in India?
I'm from Nepal, so
Yeah.
in Nepal officially there are no fillers available. They're not approved yet, but then we use biostimulators like mainly Profilo as well as Vital and Volite. But we also have recently started with PDRN recently, but these are also relatively new. Globally, as doctor has already given a full presentation on that, globally many options are there. But now I think in Korea, I've been to Korea a few times before. So in Korea, I think the combination of PDRN and HA, they're doing wonders. Although PDRN is slightly more on the painful side, but the combination of PDRN and HA is probably the future, especially in younger generation. One thing I'd like to highlight from my own experience is that when you use stimulators in younger generation, as we do skin tests in most of our younger people, most of them have sensitive skin right now. Skin sensitive is a big issue and there's no proper exact treatment for that. But in my experience, when you start doing these stimulators early on, they do help in reducing the sensitivity as well, by reducing the elastin, by breaking that chain of collagen converting into elastosis and then fibrosis, so breaking that chain of aging. So I think it's important even in younger generation to start biostimulators early now.
So in short, you're telling that when we want to start biostimulators, we started at a younger age, is what we
Yes.
want to give the message to
Yes,
people,
maybe
right?
in early 20s.
Dr. Roshali, you spoke about different biostimulators in your talk. So can you elaborate on that?
Yeah, so the HA-based Profilo, Vital and Skin Booster. Non-HA are polynucleotides, and others are, depending upon the material that is used, PLLA, polylactic acid, PCL. So these are the material biostimulator which is being used. They come in either in combination of HA or you can get a pure PLLA. So Sculptra is without HA. So these are the commonly available. Let's see what all things are.
exosomes.
Yes, Dr. Sadhna.
Also, exosomes are available now in the list of biostimulators.
Yeah, but do we tell exosomes as biostimulator?
They
that's
are a
what.
different category, I think so.
Yeah.
Yeah, because that is a biological product, exosome, which is naturally occurring. So
So in the classification of boosters, it comes in the classification, but it is a non-HA biostimulator. That's what it is there in one of the paper of classification.
Of exosomes is what you're talking about?
Exosomes. Yeah.
Okay, but how do we tell exosomes as a biostimulator? I think any injury to the skin,
So
in general, we can say that it's going to biostimulate your skin, because if you do any injury to your skin, okay, like doing procedures like
Even
PRP,
microneedling, yeah.
yeah,
Simple microneedling also is a biostimulation. But exosomes, we can take it in biostimulation because it works on the principle of parabiosis. That is, when you are introducing the exosomes of young cell into the age cell, it reverses aging. So it reverses aging by collagenosis, neovascularization, new cell formation. So that is also a biostimulation.
So in the classification of skin boosters, apart from whatever we discussed, like HA based, then PLLA, Sculptra, then PDRN, then PRP, growth factors, stem cells, and exosomes, and also even the micro Botox. They have said that this is a classification of skin boosters.
yeah, they are the classification of skin boosters, but we are talking about biostimulators.
So in fact,
Yeah.
the non-HA based will come in biostimulators only, na? Because they are stimulating.
Yeah, Dr.
the-
Roshali, you want to say something?
No, I just, whatever I read through, it is a different category all through because of the origin of the product. So like we can say PRP biostimulate, but it is not a biostimulator how the product is being made.
I think
So-
the biostimulation is the new word which has been studied now since few years, and we all will have to keep on growing towards it, and we will then come with some consensus of what is actually a biostimulator. But in short, see, there is something which actually, whatever injury you do to your skin, it is actually going to stimulate your skin and stimulate your fibroblasts to produce the collagen and elastin. But have you heard about something called as conditioned reflex in biostimulation? Dr. Roshali, yeah?
So it is I can just roughly explain that it is, we are conditioning our body beforehand to not age. So we are trying to produce more of we are training the dermis to not age to collagen 3.
So this condition reflects this also. When I was studying through biostimulation, I came through this one of the papers where it said that there is something called as conditioned reflex, means you have to condition your dermis to produce the fibroblast, but not continuously, because if you continuously keep on stimulating and if you give a high stimulation, the fibroblast would be depleted and then you would not get any stimulation. So when you do a high biostimulation, especially with the lasers or HIFU or something like that, then there is more of stimulation of the fibroblast. It produces the collagen and elastin, and then of course your body takes over. But later, then you require to give low biostimulation, which is with all the biostimulators. So there is continuously your fibroblasts are activated to produce good collagen, and hence it will help to decrease your aging process. This is how they place biostimulators in between our lasers and HIFU and other anti-aging treatments.
I think in that article, the one which you're speaking, they are trying to say that even the fractional CO2 laser is going to produce collagen. So where to place biostimulator? It is not a filler. It is more than a CO2 laser. So in that they have said that if you exhaust your dermis by doing repeated amount of laser, continuous laser like Morpheus, CO2, so there is that depletion and then we are unable to produce more
Of
collagen
fat,
after.
yeah.
So
That's what.
yeah.
It means the collagen stimulation has to be paced. Apply high level stimulation at intervals when it's required, and then you have to maintain with the low level stimulation, which is by the biostimulators. Now, this were the different papers, the evidence which showed that how the biostimulation works and how different products like the calcium hydroxylapatite, how does the Sculptra and all work. So can we just talk about it? Of course, these things are not available in India. okay? But might be, as Dr. Rochelle, you told in your talk, that 2025 would be the biostimulation era in India. So what are these products what we are waiting for?
So Sculptra is something many doctors in India also are using. It is PLLA, polyl lactic acid, and it comes in a vial where we dilute, as Sir said, we dilute it with 8 ml of normal saline and 1 ml of lignocaine. It is more for, I can say, butt lift and skin regeneration. It has given wonderful results for the body. Rather than face, we are yet to see evidence in India.
So this was one of the papers I came through where it showed that when you hyperdilute the calcium hydroxylapatite, okay, which is like normally you dilute with 1:1, but here they have diluted it from 1:2 to 1:6. And this dilute, when it's not diluted, it acts as a volumizing agent. But when it's diluted, what happens is there is absence of lymphocytic infiltrate in that area. So the fibroblasts are preserved and there is increase of type 1 collagen in that area, because of which it helps to biostimulate. So this were some of the papers where it showed how the dilution is going to help. And coming to Profilo, Dr. Chetna, you were talking about the high and the low molecular weight of Profilo and how does it act as a biostimulator? Can you tell us on that?
So low molecular weight HA, basically Profilo, there is no cross-linking. It is a hybrid technology. High molecular weight HA and low molecular weight HA are combined. Now, low molecular weight HA is the stimulator of your CD4 markers, of your growth factors, all the collagen factor markers. Whereas your high molecular HA gives the support to the dermis, it hydrates the dermis. Also what happens is, deep hydration of the dermis leads to stretching of the collagen, which again leads to expression of TGF alpha, and that leads to procollagen and collagen 1 production. So that is the mechanism of Profilo.
Okay, so that is how it differs from other boosters.
Yes.
Right? Because the boosters would not have both the high and the low molecular weight.
Correct.
And because it has both,
It is
works.
a biostimulator.
Yes.
It works for hydration also, and it works for neocollagenosis also.
Right. Now this was another study which showed the difference between the PCL and polynucleotide, and it showed both of them worked very well for the crow's feet. Now among the panelists, I want to know who has an experience about the PDRN.
I've just used it in very few patients. I bought Rezuran few years back, but then in Nepal, the information about PDRN is not that much, and the only limitation of using PDRN for me was the kind of pain that it causes. And secondly, I think yesterday it was already discussed that since it's a DNA from some other, salmon, some other species, because of that there's also a risk of, there are not adequate studies. So because of that, I have used Vitaran, I have used Rejuran. It does give good results, but in my opinion, to me, for Nepal's perspective, it is a bit expensive. So it is not something that you'll see results right away, unlike Profilo. Like you do 2 sessions of Profilo, patient will be happy. But in PDRN, you have to keep doing it, and then the cost bracket for us is the challenge. So we've not started full-fledged yet.
So how do you space your treatments of Profilo? How do you do that?
I would do it 1 month apart first, in the given kind of that 10 points that they've given. So
the
I would do
bioaesthetic points.
Yes, so I would do 1 month apart in the beginning, and then I would do every 6 months.
Okay, so you would space 2 injections in 6 months interval.
Initially 1 month apart, and then 6 months, every 6 months to 8 months,
Okay.
depending on the patient's laxity.
Other people, any comments on the same?
See, Profilo, the protocol given is you do the baseline, then after 1 month you repeat, and then after 6 months you repeat. But some people, they can do, I mean, some clinics like we do once in 3-4 months, like once in 4 months. So you divide those 3 injections over a period of 12 months. So you do once in 4 months, and that way also it lasts. and you can follow the standard protocol also. So it depends how you are seeing the hydration and how you are seeing
So
the
you feel, so
improvement.
you're telling Profilo, there are two protocols. The first one
No,
is
first protocol is like a
what the
their
standard
published
protocol. Yeah.
protocol, and the second protocol is when individual doctor may be following how they are using and how what is their experience with the results.
Okay, so you do it first sitting, then you do the second one after 4 months, and third after 4 months.
No, I usually follow standard protocol only. First injection, then the second after a month, and the third after 6 months.
Okay,
Now, some patients they are doing multiple other treatments.
right.
They are doing their erbium glass, they are doing peels, they are doing Q switch. So their skin hydration and the what you call it, the glow is maintained. So in such patients, when they want to do repeated profilos, then I tell them to do it once in 4 months when they are doing other treatments
Okay,
as well.
yes, yes. So when you're combining with other treatments, you can place it out that way. Yeah, Dr. Chetna, you wanted to.
So in my practice, Profilo is mainly for the neck. Face,
Okay.
yes, Indians are very good with the buccal fat, so I have not seen that kind of considerable result in the face. But neck, you do it 1 month apart or you do once in 3 months, the results stand out the same. I prefer doing it once in 3 months because the effect starts weaning off. Again, you have to, the dermis is very thin and you have to plump it up. So that is
Right.
where my Profilo stands.
So I want to understand from you, how do you place your Profilo? Like, what do you tell your patients? What Profilo is going to give to you? What is it? What results you get from Profilo?
So Profilo, when it comes to older patients, we honestly, combination treatment is always the best treatment because if you're talking about platysmal bands and everything, Profilo is not going to take care of it. So it has to be combined with a toxin, number one. Secondly, the repeated treatment is needed. Profilo is going to plump up your dermis. It's not going to give you volume or it's not going to make you look puffy, but it's going to make plump up your dermis, and that's how your neck skin starts improving.
Okay.
At times, I add twin screw threads also with Profilo because in long run that helps.
Yeah, Dr. Shrestha, you wanted to talk something.
There are, as we know, the sinkers and saggers, there are different kinds of faces. So especially in saggers, I would combine it with HIFU. I would do HIFU first, wait for a month, and then go ahead with Profilo. That gives good kind of lifting as well as slimming effect. And in younger people, I also do it with exosomes, although there's a controversy between whether exosomes are biostimulators or not. But I've been seeing very, very good results with exosomes, amazing results in scar as well as fine lines, wrinkles. There was a patient whose wrinkle did not go with Botox, but that got better with
So
exosomes.
how do you combine Profilo and exosomes?
I would,
How do you space
if it's in different areas of the face, for example, if you're doing exosomes for the wrinkles around eyes and on the forehead, I would do Profilo on the lower part of the face. That I would do in one session, but then if you're doing on the whole face, then I would space it out at least 1 month apart.
Okay, so it's like same Profilo and exosomes and same sitting.
Yes.
And 1 month apart is what you do.
Especially in
Dr.
older people, older patients, it has better results. As doctor said already, that in younger people, you do see results with Profilo, but in older people, it's a little more difficult for them to exactly, locate, especially in 40s and 50s. In those cases, I either combine with HIFU or with exosomes. And they're happy
Yeah,
because
so older the patient, you have to combine with other anti-aging treatments, and younger patients, only Profilo would take over,
Yes,
is what
thank
you
you.
want to say. Yeah, Dr. Roshali.
So we have patients who are in their mid-30s. They are not willing for fillers because Indian are more on a puffier side. We have very, very few patients who are very lean. So but they want something they are seeing in the mirror and they feel that they are looking aged, but they don't know what to do. Most of the laser, that's why MNRF got so much boost in India because it didn't had downtime. So we can place a Profilo over there to explain them that, see, it is not going to cause any significant difference tomorrow, but how slowly you have aged in last 1 year, you can see some differences. This is a slow maintenance thing that we are just trying to delay your aging. So it is not a magic that you will see after the injection how we do filler, but they all have seen somehow some celebrities, then they are really scared of doing fillers. So I think this is somewhere we can slip in our Profilo.
So I want to ask.
So the
then
problem is the kind of finances a younger patient puts in for Profilo, and if you're telling them that it's going to be a slow aging,
That's
they
what.
really don't come back to you. So that's why, I mean, if it is a younger patient, I might just go ahead with Volite Vital, in which they are going to shine in 2 to 3 weeks, and some results are going to be there. Whereas Profilo, for face, especially in younger patients, I've not seen much of though it is a prophylactic effect, but I've not seen much of the results.
So that's why my question, why do we invest in biostimulators? How do you convince your patients? Because it is expensive. How do you convince your patients about investing in biostimulator?
So depending on
just
the
like in 2 lines, I want the answers
depending
from
on the
everyone.
age of the patient, if the younger patient comes, glow is the only priority. Do Volite, tell them do it after 6 months and they are done, and Volite Vital and they are done with it. If it is an older patient, again divided into face and neck, and the priority areas are to be taken care of.
Dr. Sadhna?
So if younger patient, if I give any biostimulator, I tell them to do at least initially 1 or 2 sessions of, along with that 1 or 2 sessions of either a glycolic peel or a Q-switch NDR glazer, and that's how I work.
Yeah.
I think saying it will produce your own natural collagen, so will help the patient to like approach towards the treatment more easily.
I would say one sentence that the Gen Z is aging faster than millennials. Right, so they're aging. So when we do skin tests from the same family members, the younger ones have more collagen loss, more UV damage, more sensitivity. And this will definitely be better when there's a better collagen support in the skin, because all diseases, after all, including melasma, would start with the collagen loss. So if we explain properly, and then I also ask patients to go back and search, do their own research, and I'll tell the cost. And then if they think it is valuable enough, then they would do it.
Yeah, because nowadays we get patients in our clinic. Initially, you remember patients were never using retinol on their own.
Correct.
Nowadays, because of social media, we get patients who have always been applying retinol, niacinamide, hyaluronic acid, everything. So what else do we have to offer? I think then, as dermatologists, we need to educate them that apart from whatever the skin care you are doing, you can. These are the injections which you can take and which will help prevent the aging.
Also, Gen Z, millennials, so for that matter, we are an impatient generation. We are not going to wait for hydrofacials, peels to take over every time and come back to you.
Yeah.
So nowadays, the generation wants to try new things, and if it works, they just stick to it. So that's why I think skin boosters have taken a hype, wherein the results are there within 1 to 3 weeks, and they don't need to come back to you again and
that's
again.
what. They don't have to come again and again. And plus, as dermatologists, we have something more to offer it to them. What they are doing.
Because
Yeah.
when it comes to glow, when it comes to the quality of skin, it's a very subjective thing. And telling them ki you'll have to do facials every time, peels every time, it becomes a little difficult to retain them. But once you do Volite and you show them a little subjective difference, they are definitely with you.
So let's go through the images of few patients over here. Now this patient was 25-year-old female, and she just came to me that of course she had acne which was all resolved, and she had few acne PIH. But she wanted some kind of glow to her face. She was not happy with her face. What would you do, Dr. Sadhna, for this patient?
See, I mean, I know that this is a topic of boosters, but such patient coming to us for the first time, straight away I won't tell her boosters.
Yes.
I will tell her to, of course, if they are not using any actives, add that sunscreen, and I will do Q-switch NDR laser because her main concern is pigmentation.
Okay, fine. Dr. Roshali?
Yeah, I agree with her. I would not counsel her for biostimulator at the first go because it is not going to make any difference immediately. And she is, I think, more concerned about the acne PIH and the perioral hypopigmentation. So she need that fairness kind of glow. So I think NDIG or chemical peels or yellow peel, something like that.
So my thing of putting the image of this patient was, of course, apart from the skincare, what we have been advising to the patient, apart from other skin treatments like the chemical peels or lasers, when it comes to biostimulator, I'm not telling that you have to do it, but when it comes to biostimulators, I would want you all to answer that which one would you prefer? The HA based, the non-HA based, which ones would you prefer in this kind of patient?
So many a times such patients come just prior to your wedding or something, they need a immediate. So I will give her the option ki yes, there's going to be a long-term treatment, but if you're looking for instant gratification,
Yeah, just fine.
it is the skin boosters.
Yeah.
If you're looking for immediate results, it's the skin boosters which is going to help you. See, we are not looking at just one spot or one perioral, but it's the global, the face which I have to look at.
Right.
And that's how it will improve the hydration, improve the reflection of the light, so she'll look lighter, brighter, and maybe happier. So that will improve the confidence of the patient.
Okay. Now this patient, I had done only the PDRN booster. Apart from other treatments, what of course we have been doing, like the FSR and the microneedling MNRF also for her scars and open pores. Apart from that, she was treated with PDRN 2 sessions, 1 month apart.
Very good results. Wonderful.
Now the other patient, she is in her 40s. I just want to know from Dr. Shrestha, which biostimulator would you give her? Apart
She
from
has a
all
lot
the
of-
other treatments, what we do.
Yes, she has a lot of texture issues from what I see. So I think she would get better with probably with PDRN, although I don't have too much experience with that, but the kind of texture that I see, and of course the lifting can be done with Profilo, but she would get better with PDRN. If she's looking for immediate results, skin boosters will also do the job.
Okay. Just take okay, just 2 minutes and we'll be done. Okay, just few patients, 1 or 2 images of the patients. Yeah, okay. What? So this patient was treated with the HA based, means Profilo also, and with the non-HA based because she had dark circles and periorbital melanosis with acanthosis. So around the eyes, she was treated with the PDRN and all over the face with Profilo. Now, when this kind of patient comes who are in their 40s and 50s, of course, they would require volumization also with the fillers and the Profilo together or even PDRN to boost the effect of volumizing.
In the last patient, the melasma seems quite significantly improved. Can you
Yes,
please advise
yes.
what treatment you had done for her?
So this patient, I had given her the fillers and of course I had given her Profilo. So Profilo worked very well for the melasma also. Now the side effects and all, I think that we can. One thing what I want to ask is when the patient comes to a clinic and if they tell, today I'm taking, but later if I don't take these injections, what will happen? Just one answer I want from every one of you all. Just last question and I'm done.
Usually this question is asked even with Botox. So I would generally say that the duration that you do it for the, like, for example, 5 to 10 years time frame, that duration at least will improve. So for example, if you stop doing in your 40s, at least from 30 to 40, you'll have the results that will make you not completely like 30, but then the results will be better until the duration that you continue.
Okay, Dr. Rashali.
I always tell them that these aesthetic procedures are like doing your eyebrows. No one is forcing you, but once you do it, you love it, so you go back and get it done again.
Okay.
So
I tell them that if you decide to stop this, you can, but at least continue on your applications and sunscreen.
Right.
That you should never stop.
I tell them because these are biostimulators, some amount of stimulation is going to be there till you stop for a year or two, but then eventually you'll come back and do it to me. Do it.
So that's what I tell them, that you are going to age as per your genetic timeline. So there is no evidence that stopping these injectables will accelerate your aging. You are going to age as what you are going to age, right? So in short, what does this do? The biostimulatory injections help to improve your skin tone and texture, improve skin firmness, hydrates the skin, and stimulates collagen and elastin. Thank you so much for your patient hearing.
Thank you. Thank
Thank
you so
to all
much.
my panelists. Thank you so much.
Thank you so much. I would request our esteemed panelists to please come forward and felicitate our moderator. Ladies and gentlemen, please put your hands together as we felicitate our moderator. I would request Dr. Kailash to please come up on the stage as we have Dr. Chetna among us from the esteemed panelists whom we would like to felicitate. So, thank you so much, sir. And here we are felicitating Dr. Chetna. Everyone, please put your hands together for Dr. Chetna. Now, ladies and gentlemen, as we are moving forward towards our next session, for our next session, I would like to invite our chairperson here on the stage. Everyone, please put your hands together for Dr. Vikram Rathore. Can we have you here? Everyone, please put your hands together for Dr. Vikram, Dr. Pascal D'Souza, Dr. Dharmendra Karn, Dr. Rupak Gimre. Can we have a big round of applause for all the chairpersons who are present and are joining us here on the stage? Now I would request our chairperson to please introduce our very first speaker to the audience present here. So the first one who's going to come here with her speech, and her name is Dr. Shivangi Rana. Can we have a big round of applause for Dr. Shivangi?
Hello. Good morning to all of you. Thanks to the organizers for giving us this opportunity to be here with you. This is a Sodvilon session, and I'm delighted to introduce the first speaker, Dr. Shivangi Rana. She's Assistant Professor, AIMS, Gorakhpur, a member of IDVL SIG Acne, winner of IDVL Kiwi Poster Award for the Best Poster Dermacon 2015. And she's going to talk to us about an exciting topic on facial vitiligo, advanced treatments available. Dr. Shivangi, please.
Thank you so much, sir, for the introduction. So, at the outset, I would like to thank the organizer, Dr. Ramanjit, sir, and Dr. Rana, for inviting me here and for this opportunity. So, first of all, just moving from aesthetics to the clinical. So, my topic for today's session is facial vitiligo and advanced treatment. So, in this session, I would like to focus mainly the treatments, the newer advances that are particularly in respect to the evidence which is available for the treatment of facial vitiligo. Okay, so as you all know, that we basically classify vitiligo into the majorly three types: the segmental, non-segmental, and the mixed variant. So in respect to the face can involve in all these types of vitiligo: segmental, non-segmental, and mixed. But exact data as to what is the exact prevalence of the number of patients in which there is facial involvement is still unknown. And it is found that the face and neck is involved in 26.3% of the cases of vitiligo, and head and neck was the initial site of onset in 52.6% in segmental vitiligo patient. So in brief, you can say that in segmental vitiligo, it is majorly the face and neck which is involved. So this classification was given here back by Han et al. In 2000. They have categorized the segmental vitiligo over the face into the 5 categories. The type 1, which is the most common type, is where the lesion starts from one side of the face, majorly from the forehead, then it crosses the midline, and then it involves the contralateral side of the eyeball, and then it progresses downward. So this is the most common type of vitiligo that is found over the face. Then there was type 2, where basically the lesion starts from the between the nose and tip, and then it progresses toward the periauricular area. In the type 3, majorly the lower lip it is involved, and then it spread to the chin and the neck area. In type 4, it is the lesion starting from the right side of the face, but it does not crosses the midline. It remains over the same area, and it progresses downward toward the same area and reaches to the lower part of the jaw. And lastly, the type 5, which is confined mainly to the cheek area, and this is the least common type. And in this same study, they have said that the segmental vitiligo is quite common over the face, but it is also found that it will not always follow a dermatome and or any Blaschko line. So you can see various kind of, different kind of involvement when it is particularly the face involvement in vitiligo. And also it is found that there is no statistical association between the distribution of the initial lesion, progression pattern, and the clinical type of vitiligo. And also they have found that there is some kind of facial segmental vitiligo over the face which cannot be categorized in any of these 5 types. So this is what we know, the topicals that is available with us, the steroids, calcineurin inhibitors, vitamin D analog, 5-fluorouracil, fibroblast growth factor, pseudocatalysis, photochemotherapy, and the systemic drugs, steroids, and various steroid-sparing agents. So today I will not talk about any of these. My focus will be basically what we have apart from all these and when we are basically treating the face vitiligo. So before going to the treatment part, I would like to first focus upon the basic pathogenesis. As you all know, is basically the 4 things that are involved: the genetics, the autoimmunity, the oxidative stress, and the neural hypothesis. So where we are focusing? We are mainly focusing the autoimmunity and the oxidative stress when we are considering the advanced treatment. Now, why face vitiligo? Why do we need a treatment advance, or why we are talking about the face vitiligo? Because involvement of face definitely associated with the maximum psychosocial impact, and it is associated with a very low self-esteem. These patients will present to you at a very early stage, and they want a very early result also. And not all treatments are safe in vitiligo, and they are not effective over the face. And the corticosteroid, which is the cornerstone of treatment of vitiligo, it may be associated with a potential adverse effect when we are treating the facial lesion, and therefore we need some more topical agent which we can give for the we can give safely, and we can give it for the long time also. So first of all, we will begin with the medical treatment. In the medical treatment, first thing and the most talked drug is the JAK inhibitors. So where are these JAK inhibitors actually acting when we are talking about the vitiligo? Here I would like to show you that this is basically the epidermis, okay? And here are the melanocytes. And in this part of the dermis, you can see that there are multiple, lymphocytes that are present, that is commonly seen in active vitiligo patient. Now what is happening? So we are focusing in this area where these are the melanocytes, and these are the autoreactive T cells which are present over the dermis. So main component here is the TNF alpha. So there are many cytokines which are released, but since it is a kind of a vicious cycle that is going on. So this TNF alpha, which is released from the autostimulatory T regulatory cells, it acts in the keratinocyte via a JAK1 and JAK2 pathways. And it releases the CXCL9 and 10, which then stimulate the CXCR3 activated T cell. And these T8 cells, again, they are migrated into the lesion site, and they further releases the TNF alpha, and they causes again T regulatory cell stimulation, and this cycle goes on. So you can see that this is a kind of a vicious cycle which is going on. So where we can halt this cycle? We can attack this JAK1 and JAK2 pathway, where we can halt this process going on. So here the TNF-alpha can be blocked. Here the ruxolitinib is basically the molecule which will help here. And second, we can target JAK3 and JAK1. This is the interleukin-15, which is the most talked, cytokine nowadays with respect to the vitiligo pathogenesis. This acts via the JAK1 and JAK3, and then it further stimulate the T-regulatory cell. So these two drugs, they are the newer molecule which can help in the vitiligo pathogenesis. So let's talk about them. First of all, topical ruxolitinib. So ruxolitinib is a JAK1 and JAK2 inhibitor. So it is the first topical JAK inhibitor which is FDA approved for treatment of non-segmental vitiligo, which is affecting less than 10% of body surface area, and in adults and children, which is above 12-year-old. So we have phase 2 and phase 3 trials on topical ruxolitinib, and this is basically done in the facial vitiligo. So what was the result? They have seen that there is more than 75% improvement in facial VASI scoring when compared to the vehicle after the 24-week of treatment, and this pigmentation was persistent even in the follow-up study also. At the end of 52-week also, this pigmentation was persistent. And also when it was combined with narrowband UVB, this was an additional benefit in the facial and the total body repigmentation. So what was the adverse effect? So adverse effect are very few. Mostly it was acne and pruritus. And the most important concern was the maintenance of the pigmentation after discontinuation of therapy, because the results which was given in the phase 3 trial was only up to the 52 weeks. So the extension of the repigmentation lasted up to the 60 month in phase 2 trial. However, the number of patients included for the extension study of the phase 2 trial were very less. So coming to the next drug, that is the retlicitinib. Retlicitinib is not available topically. It is an oral drug which is basically a JAK3 inhibitors, and it also inhibit the tyrosine kinase family. So they inhibit basically by inhibiting the signaling of interleukin 2 and 15, which is I've just shown you in the previous slide. In the phase 2 trial, it was shown that the 50 milligram of retlicitinib causes significant difference in the percentage change of facial vitiligo when it is compared to the baseline, and it is used both with or without the loading dose. Next drug is efidancitinib. Efidancitinib is a JAK1 and 3 inhibitor. It is topically available, but the phase 2 trial is still undergoing, especially in patients of facial vitiligo. So to conclude, in the JAK inhibitors, among all the JAK inhibitors, ruxolitinib was the most common topical therapy which is used, followed by tofacitinib. This is not in respect to the vitiligo alone. This is in respect to all the dermatological condition that was seen. And topical ruxolitinib is an emerging and a very promising treatment for vitiligo. They have a potent effect on the pigmentation, and this pigmentation lasted for a very long time also. What about topical tofacitinib? So I have not mentioned anything about topical tofacitinib here because we don't have a very good data regarding topical tofacitinib in respect to, again, treatment of facial vitiligo. This article is basically a meta-analysis which has shown the repigmentation of vitiligo using a JAK inhibitor with phototherapy. So in this meta-analysis, it is concluded that the concurrent use of UVB phototherapy, it improves the JAK inhibitors used in vitiligo, and facial vitiligo has a highest and a good response rate compared to the extremity and the non-sun exposed area. And so in the last, I would say that JAK inhibitor, they are a very good targeted approach when we are talking about the therapy in vitiligo, especially for the facial vitiligo. And it has a better response when we combine it with the other modalities, commonly with the phototherapy. Next modality, next option which we have is a prostaglandin analogs. So prostaglandin analog, it was used in vitiligo when initially we see that there was reports of hyperpigmentation, periocular hyperpigmentation, when prostaglandin F2 alpha was used for the patients of glaucoma. And this research was again then, following this, many researches was done to see what its effect on the vitiligo patients. So they basically act by stimulating the activity and expression of tyrosinase. And PGF2 alpha is also one of the known marker for oxidative stress. So they basically acting via the oxidative pathway. So after this, there were many researches which was done. All these researches were done, and the conclusion is that topical 0.01% bimatoprost, it is effective in facial vitiligo when it is used alone or in combination with narrowband UVB, microneedling, or with topical corticosteroids. Latanoprost has been tried topically as well as intralesionally also in patients of vitiligo, and it is found to be effective when it is used in combination with microneedling, CO2 laser, and narrowband UVB. And the clinical trial is still undergoing where they are comparing the topical latanoprost with 5-fluorouracil in patients of facial vitiligo. Okay, so this is the meta-analysis. So this meta-analysis of role of prostaglandin in vitiligo patient, it concludes that the prostaglandin analog significantly increases the repigmentation when it is used along with narrowband phototherapy as compared to phototherapy alone. And this repigmentation efficacy was found not significantly better than that of tacrolimus. So the conclusion is it is good when used combination, but it is not better than tacrolimus. Then comes this one. It is a recent study where they have compared the prostaglandin F2 alpha level in the lesional as well as the non-lesional skin of vitiligo patient. And they have found this, contrary to the previous study, the levels were same in both the lesional as well as the non-lesional skin. And they have hypothesized that this periocular hyperpigmentation could be because of the base ingredient of the ointment and not because of the active prostaglandin.
Please.
So I will just conclude in 2 lines that this is a good drug, but again, it should be used in combination with other therapy. Then we have alpha-melanotides. The alpha-melanotides is a synthetic alpha-MSH. It is basically active and potent form of alpha-MSH, which is basically, again, acting via the oxidative pathway. It is given in the subcutaneous injection form. Okay, we don't have many data with alpha-melanotide. It is always used in combination phototherapy, not alone. And the combination result is has given a better result in non-segmental vitiligo, but it is not being used in facial vitiligo patient. And I'm not able to change the slide. Slide is not changing. Even my half of presentation is not complete. So basically, this trial is still ongoing where they are using alpha-melanotide in patients of facial vitiligo. Okay, so alpha-melanotide is a promising role, but again, it cannot be used alone. Will not change. Am I not able to? I have to complete my presentation, right? Please, I get to make it. I'm not able to change the slide. How do I click this?
Dr. Shigavangi, humble request to all the speakers who stick to their time is already behind schedule.
I'll
I
just
think
move
we
on
can.
to the slides, sir, but at least I should
maybe.
be able to change the slide.
So
because I just covered half of my
or
presentation.
you can just say a few words, whatever you wanted to conclude in that.
And there are a few more molecules which I would like to talk. Okay. Is it changing or not? Okay. So apart from the molecule which I've shown you, there are a few newer therapeutic agents which are still under trial, mainly the microRNAs. The microRNAs also. Okay, I will not go in detail. So methotrexate gel, only one case report is there, which is used in stable vitiligo. In the neurotherapeutic rapamycin, just one line I would like to say. This rapamycin topical is still under phase 2 trial in the patients of vitiligo. And WNT signaling pathway, initially it was much hype that the WNT signaling pathway has a major role in vitiligo pathogenesis. Only lithium and simvastatin was found to regulate this pathway, but it was found that this is simvastatin, it does not correlate the uptake of this simvastatin with the repigmentation. So we don't use it for the patients of vitiligo. Okay, now microRNA is one of the emerging therapy where it is a kind of a non-coding mRNA. It is found to be associated with melanocyte proliferation, and its serums level correlate with the monitoring of the therapy with the disease severity also. But still we have only okay. Last, I'll just like to tell about the surgical, only the last part. With surgical modality, I would just like to say all the surgical modalities, they have same results, in the facial vitiligo, nothing different. Only the excision is being tried for the lip vitiligo, and even the flap, mucosal flap we can try. Okay, thank you.
So much. Thank you so much. And I would request Dr. Shivangi to please come at the center of the stage, and I would request one of the chairperson to please felicitate Dr. Shivangi. Ladies and gentlemen, please put your hands together for Dr. Shivangi. Thank you so much. And now, as we proceed towards our next speaker, I would also request our chairperson to introduce our next speaker. But before we call our next upcoming speakers here on the stage, I would request you all to please make sure that I think we have given 10 minutes to each speakers. Make sure that you do watch the time and keep it within the time span, because we have lots of speakers. We are already running late, so please make sure that you complete your PPT within the given time. Well, coming up towards our next speaker, we are going to invite here Dr. Mohan Bhushal. Can we have a big round of applause for Dr. Mohan? I would request our chairperson to please introduce our next speaker.
Our next speaker is Dr. Mohan Bisal. He is an MD dermatology and a lecturer at Nepal Medical College, Jorpati. He has his own clinic, Miracle Skin and Hair Clinic in Kathmandu. Very young and budding dermatologist. He is a top ranker of MD dermatology. He's got received numerous scholarships and also an associate member of ISHRS and country representative for FU Asia with his special interest in hair transplant and aesthetics, Mohan Bisal.
Thank you, Chairperson, for the kind introduction. Without further delay, I would like to congratulate the FADS on behalf of the Society of Dermatology, Venerology and Leprology of Nepal as a joint secretary of the organization. So without delay, I'll be talking today about acne and rosacea, the difference in the treatment. Before 2016, acne rosacea used to be called acne rosacea, and the term has changed to rosacea now. So in our skin type, especially skin type 4 and 5, it is further confusing because of most of the symptoms are masks because of the skin of color. So I'll quickly move on to that. I have no conflict of interest to declare. So rosacea and acne both are chronic inflammatory condition. Rosacea is a common chronic inflammatory disease which predominantly affects the central face, and occasionally it can also involve the forehead and chin, and can also involve the eye, called ocular rosacea. Initially, it is characterized by recurrent erythema, telangiectasia, and flushing, and later the inflammatory component predominates with persistent erythema and follicular papules and pustules, usually common in the middle age group with a light skin type, type 1 and type 2, but not uncommon in our skin type as well. Prevalence ranges anywhere from 0.09 to 22.41%, with the mean being 5.46%. Pathogenesis is basically an immune dysfunction and a series of inflammatory response to cutaneous microbiome like Dermatodex follicularis, leading to vascular dysfunction. And also there is a role of UV exposure, and genetic susceptibility is also a very important factor. So it was initially classified in 2002 based on the subtype as erythrotelangiectatic, papillopustular, phymatous, and ocular. But the classification changed in order to, because diagnoses were missed, and so the classification was broadened in 2017, and it was classified under 3 different headings, like diagnostic phenotype, major phenotype, and minor phenotype. The diagnostic phenotype being persistent facial erythema, 5 changes. The major phenotype being transient facial erythema, inflammatory papules and pustules, telangiectasia, and ocular changes. And the minor phenotypes being burning sensation, stinging, edema, and dryness. And in order to diagnose the rosacea according to this new classification, either 1 diagnostic criteria or 2 major phenotypes are sufficient for the diagnosis. While we talk about acne, so acne is a chronic inflammatory skin disease of the pilosebaceous unit, affects primarily, it presents with the open or closed comedones, papules, pustules, nodules on the face or trunk, and also sometimes it may result in pain, erythema, hyperpigmentation, or scarring. It is more common than rosacea. It is around it affects around 9.4% of global population according to 2010 data, and it is the 8th most prevalent disease globally. And its prevalence in adolescent and young adult is as high as up to 85%. The pathogenesis being complex interplay of androgen excess, innate and cellular immune response that is influenced by genetic susceptibility, and there is some role of diet as well. So how to differentiate this acne from rosacea? So although all the variants are not confusing, but the inflammatory variants is usually confusing with the acne, and we need to differentiate it. So age group, usually acne occurs in adolescent and young age group, whereas rosacea usually occurs in the middle age group. Acne is more common, it can occur in any skin type, whereas in rosacea it is more common in type 1 and type 2, as I already mentioned, maybe because it is more visible in that skin type, and in our skin of color it might be less visible. Triggers are usually stress, obesity, dairy product, white chocolate, high glycemic food in the case of acne, whereas in rosacea, there are specific triggers like hot, spicy food, alcohol, sunlight, and few others, emotional outburst as well. So the lesions are usually acne, they are the polymorphic lesions. Comedones are the pathognomic lesion, whereas in rosacea, the lesions are usually monomorphic and comedones are usually absent. Symptoms, acne is usually asymptomatic. Sometimes it can present with itching or burning as well, but rosacea is predominantly symptomatic and it presents with itching. And adrenal hyperplasia, whereas in rosacea, it is associated with sensitivity and flushing. So this is the picture showing the acne distribution in the face and truncal area, whereas in rosacea, it is in the sun-exposed upper face and upper neck area only. So the lesions being in acne, comedones and inflamed papules, pustules, and nodules, whereas as you can see on the right side, there is a centrofacial erythema, telangiectasia, inflamed papules, and pustules in case of rosacea. And in skin of color, as you can see here, the symptoms are so marked compared to the picture I showed earlier. So for acne and rosacea, we need to do some workup. In acne, we need to work up for signs of hypoandrogenism, virilization, hirsutism, irregular menstrual cycle. And in rosacea, we need to always rule out ocular involvement in rosacea, which can be very life-threatening as well. And in some cases, we might need to do a biopsy to rule out granulomatous rosacea as well. So acne, as I already mentioned, is associated with these symptoms, whereas rosacea is also associated with certain other systemic conditions as well. There is studies have shown strong association with inflammatory bowel disease and modest association with IBS and some association with celiac disease, and also with autoimmune diabetes mellitus, RA, multiple sclerosis, and some malignancy are also seen to be mildly associated, like thyroid cancer and BCC. And also rosacea is not only a skin-limited disease, it might sometimes go beyond that, and it is found to be associated with neuropsychiatric manifestations like migraine and depression. So these are the different most common triggers that we can see in rosacea according to the prevalence. So when we talk about treatment of rosacea, so whatever be the spectrum, so first thing we need to focus is on the general measures like patient education, avoidance of the triggers, and sun protection, skin care, and they need to be follow up with the doctor regularly. So doctor-patient relationship is very important, and some self-help group might also help to boost their confidence. And if necessary, we might also need to do psychological counseling if they are psychologically upset. So in the initial stage, if it is just in the flushing, persistent erythema, or telangiectasia, the approved drug. This is according to the S2K guideline of the rosacea, recent one. So topical brimodinine alpha agonist has a good role as a vasoconstrictor, and it helps to relieve these erythemas and symptoms. Whereas there are off-label drugs like beta blockers, which can be used for persistent erythema, and also like physical intervention like IPL and laser devices can also be used, both for telangiectasia and this. And for the inflammatory lesions, we can give, if it is mild one, topical therapy like ivermectin, azelaic acid works good. Whereas if it is a severe inflammatory lesions, then not only topical, we might have to go to low-dose doxycycline, anti-inflammatory 40 mg. And in severe cases, combination of topical and systemic treatment has to be given. And it has to be maintained with the topical therapy like ivermectin, azelaic acid, and metronidazole. Whereas if it is a phymatous rosacea, then this topical therapy will not work. We have to go to the systemic therapy like low-dose isotretinoin, ablative lasers, and surgical intervention. And in case of rosacea, apart from the preventive measures like lead hygiene and everything, topical cyclosporine has a good role, and systemic therapy like doxycycline, azithromycin has also been found to be effective. And in physical modalities, IPL laser can also work good. In case of acne, this is the acne management according to the 2024 American Academy of Dermatology guideline. So first thing, we need to assess the severity according to the global assessment score, and if it is a mild one, we treat with the topical agents, and always it is advocated that we don't use a monotherapy. Fixed dose combination of retinol and topical antibiotic is much advocated, and in the topical antibacterial also, benzyl peroxide has been found to be very effective because there is no resistance to benzyl peroxide by the bacteria. So that has been advocated, and it has been given a strong recommendation for this topical antibiotic and or topical retinoid and benzoyl peroxide combination. Other conditional recommendation in favor of intervention is for clascoterone, salicylic acid, and azelaic acid. And there is a newer modality like physical modality like pneumatic broadband light added to the adapalene can be used in the mild. Whereas if it is a moderate or severe form, papulopustular or nodular form, then systemic antibiotics, as we all know, is the gold standard. We can start from doxycycline, which has the best evidence. Doxycycline does good over azithromycin, according to this various trials. Others that can be used are minocycline, sericycline can also be used, but they are given conditional recommendation in favor of intervention only, not like doxycycline. We can use hormonal agents based on the patient's acne response to the previous primary treatment, or if it is a distribution is in the hormonal, or there are other signs of hypoandrogenism, then we can use OCPs, fourth generation OCPs, and spironolactone can also be given. And in this guideline, intralesional corticosteroid has been pushed much for like focal lesions. They have a very good role, and isotretinoin, either standard or lead-dose isotretinoin can be given. So I would like to conclude by saying that papulopustular variant of rosacea is an important differential diagnosis of inflammatory acne. Clinical presentation of rosacea in person with skin type 4 to 6 is less clear, creating diagnostic challenge. So classical distribution of the lesion, associated symptoms, and triggering factor might be helpful to distinguish between these two entities. So thank you very much. This is the beautiful picture of Himalaya. And I'd like to invite you all in our upcoming society meet, that is Sortvelon meeting, which is going to be held from 28 to 29 March in the beautiful city Kathmandu. So our organizing chairperson is here as a chairperson of this session. We have many who are in the committee here in the floor. So I'd like to invite you all in the Kathmandu. Thank you.
Thank you so much, sir, and I would request you to please come at the center of the stage, and I would request one of the chairperson to please felicitate Dr. Mohan. Ladies and gentlemen, please put your hands together for Dr. Mohan. Thank you so much. And now moving ahead towards the next speaker of the day. And for this, I would like to invite here on the stage Dr. Suchna. Can we have a big round of applause for Dr. Suchna? Meanwhile, I would also request our chairperson to introduce Dr. Suchna.
Dr. Sujna Maratha. I know personally, she is very eminent dermatologist. She is working in DI Skin Center in Kathmandu, and she is associate professor of BPKHS, and she has several achievements. The International Advisory Committee member, Global Dermatophytes Resistance Registry Leadership Group. She is the deputy editor of NJDVL, and she is a member of ILDS and ILDS Dermlink Award 2020, a WCD Rising Star Award. She got the Emeric Sarkani Award 2019, then Paper Award ICTD 2016, then invited faculty speaker in different events and national and international and globally. So over to you, Dr. Susan.
Thank you, sir. Good morning and namaste. How to move this? How to change this? It's not changing. Just pressed, it's not changing. Meanwhile, good morning and namaste from Nepal. I'm representing Society of Dermatologists, Venerologists and Leprologists of Nepal. So today I'll be talking on minoxidil versus hair peptides. I know this is very a common topic, probably most of us are using it, but still I'd like to recapitulate and highlight some of the points. Yes, moving to minoxidil, I think this is the most commonly used molecule by the dermatologist for hair loss. Just to revise, this is a prodrug. Minoxidil is a prodrug which changes to minoxidil sulfate by the sulfatyl transferase, which is present in the hair follicle. And it acts by vasodilatation of the arteriole. And it is hypothesized that it upregulates WNT beta-catenin signaling pathway and stimulates production of vascular endothelial growth factor and stimulates hair growth. So if you go in minor detail, it reverses the miniaturization of hair follicle, increases the blood flow in the hair follicle, and it stimulates hair follicle movement towards the growth phase, and it extends the follicular growth phase. That's how minoxidil acts for hair loss. However, search for newer mechanism of action and pathomechanism has still been going on. This is a recent study in which they have highlighted that 17-alpha hydroxylase and aromatase are two important steroid receptors where minoxidil has worked on in addition to other androgenetic receptors. So still a new thing has been identified for the mechanism of minoxidil. We know that it's been used for androgenetic alopecia in men and as well as for female pattern hair loss, which is FDA approved. However, other offline uses of minoxidil includes alopecia areata, central centrifugal cicatricial alopecia, chemotherapy-induced alopecia. I use quite frequently in frontal fibrosing alopecia. Also in woolly hair syndrome I have used in few patients. Also sometimes in telogen effluvium, though it's controversial, in chronic type of telogen effluvium, it really works. And it's been said that in 90% of the men and 80% of the women with hair fall, it has positive response. In this particular systematic review and meta-analysis, they have said that 5% minoxidil is superior to 2%. I'm sure most of us are using 5% these days. Initially, we used to start with 2%. However, 5% is found to be much efficacious in terms of increase in hair density and conversion of villous hair to terminal hair. And initially, because of its side effect profile, we used to start with 2%. However, now much safer version are coming. So I always start with 5%, and recommendation also says this efficacy of 5% is more than that of 2%. This guideline has also suggested unanimously, most of the authors, they have found that 5% minoxidil topical application is superior to 2% one. So this is result in one of my patient just after 4 months of minoxidil monotherapy. Now moving to peptides. Peptides are small molecular amino acid chain containing less than 50 amino acids. It stimulates hair growth by promoting hair follicle growth and increasing blood circulation, increasing hair follicle nutrition, and anti-inflammatory effect on the scalp. Commonly used peptides molecule are copper peptide, which improves scalp circulation, boosts collagen and elastin production. It also has antioxidant activity, which promote growth factors in the hair follicle. Similarly, biotin peptide, which is biotinol tripeptide, is the most commonly used molecule, which increases blood flow into the scalp. Keratin peptide helps to support the hair growth. Acetyl tetrapeptide, it has got anti-inflammatory effect on the scalp. Similarly, hexapeptide, it has got, it can convert villous hair to mature hair and collagen stimulation. Procapicyl, capexyl, these are also very commonly used peptides and biomimetic peptides in the cocktail of hair peptides. Formulation, topical formulation, which is like present in conditioner, hair mask, serum, shampoo, and all. So we can have a variety of hair products containing these peptides these days. Even injection and mesotherapy are available as peptides for hair growth. And oral formulations are also available. However, as the digestive enzymes digest them very easily, so the bioavailability is not very good. There was a randomized control trial comparing peptides versus placebo in Atilogen effluvium recently. They used 2 ml of biomimetic peptide using microneedling needle with 0.2 mm microneedles. And they did 16 sessions in 3 to 4 days apart. And they have found that there is significant improvement in hair density, anagen hair density, both in parietal and occipital area of the scalp after the treatment, after the completion of treatment, and was maintained even after 6 months of the after stopping the therapy. So this was a good study. However, in case of placebo, there was not much improvement, and the result was not significantly better. There was another study in which peptides was used in androgenetic alopecia as well, and they have used pressure-injected peptide solution using the device. And in this also, they have found that there was significant improvement in hair density, cumulative hair thickness, follicular units, and then overall density of the hair in comparison to control group in the study group, drug group, peptide group. So this was the trichoscopic picture showing the distinct difference of anagen, increase in density of the anagen hair in the treatment group. This was one of my patients. I used mesotherapy solution, peptide solution for the hair loss. And this image is after 3 sessions of mesotherapy peptide solution, 2 weeks apart. That is on the 4th follow-up of the patient. This was another patient. After 3 sessions, when she came for the 4th follow-up, I used mesotherapy solution, peptide solution, 2 weeks apart with microneedling with 1.5 mm derma roller. Again, coming to another recent randomized trial. In this, they used biomimetic peptides in alopecia areata. So in alopecia areata also they found that After the completion of therapy, 3 months before and after, there was significant improvement in SALT score grading in the treatment group in comparison to the control group. This was very unique patient. He actually presented to me for the frontal thinning, and he wanted to go for hair transplantation. However, as the miniaturized hair are still possible to grow, I suggested him to go for minoxidil and PRP therapy. However, he denied minoxidil because of the initial fall. Because most of the patients, they are reluctant to use minoxidil as they have believed that it causes hair fall. That is true also in the initial stage. And then they need to apply it throughout their life, and that's somehow true also. So he denied to go for minoxidil, and then I suggested him to start with peptides and go for PRP therapy. However, he could not come for the PRP therapy meanwhile, but after 6 months, he presented with such a good growth of hair and improvement in density just with peptide monotherapy and oral biotin. So that was amazing patient and amazing response to me also. If we summarize the difference between minoxidil and peptides, basically minoxidil acts as topical vasodilator, and peptides has got variety of action in hair growth complex. If we compare the effectiveness, minoxidil promotes hair growth in patterned hair loss. However, progressive hair loss after stopping the minoxidil is the limiting factor for you opting for minoxidil by most of the patient, and it's found that 12 to 24 weeks after stopping the minoxidil, the hair comes back to the previous stage. In peptides, the post effect is still not well known, and it's in the early stage of the study. We still need to have further evidence to talk on its effectiveness and longevity of the result. However, it could be a best choice in the initial phase as well as in the maintenance phase of hair loss, and also for telogen effluvium, acute and chronic form. This could be one of the better choice. And I suggest to go for peptides mesotherapy if your patient is not willing to go for PRP or topical minoxidil or this type of therapy. So this could be one of the best option. Minoxidil is available both as topical as well as oral formulation. Peptides are also available as topical, oral, or mesotherapy solutions. However, oral is not that viable because of its bioavailability through the GIT. So if you talk about the adverse effect, minoxidil can cause temporary telogen effluvium, which is the limiting factor to start minoxidil in most of the patient in acute telogen effluvium or even in other telogen effluvium. And it can cause scalp irritation, redness, unwanted hair growth in other part of the body, and sometimes hypotension. However, peptides are very well tolerated molecule. Yes, thank you. This is my workplace with my team. I would like to invite all of you, though previous speaker has already invited. Again, I'd like to take this platform to invite you in our Sot VeloncCon 2025. Please join us in Kathmandu. Thank you, FADS. Thank you, Sot Velon, for this platform and this opportunity. I feel extremely privileged to be with you. Thank you. Thank you so much, Dr. Sushna. I would request you to please come right at the center of the stage, and I would request one of the chairperson to please come forward and felicitate Dr. Sushna. Meanwhile, I would also request like to request Dr. Ramanjit Singh, sir, to please come up on the stage. One of our chairperson has to leave, Dr. Dharmendra Karn, and to felicitate Dr. Dharmendra Karn, I would request Dr. Ramanjeet Singh, sir, to please come up on the stage and felicitate our chairperson. Ladies and gentlemen, please put your hands together as we are felicitating. Thank you so much. Thank you so much. I would request you in case if you want to leave. Okay, so even he wants to hear our next speaker, and I would request our rest of the chairperson to please take your seat. Thank you so much, sir. So our next speaker needs no introduction, and ladies and gentlemen, please put your hands together for Dr. Ganesh Pai.
Thank you very much.
With your permission, sir, I would like to introduce you, but you don't need any introduction. It's truly an honor and privilege for me for chairing the session and featuring my respected teacher, Professor Dr. Ganesh Pai. Sir has been a guiding light or inspiration for last 20 years for my professional journey. And his contribution to the field are unparalleled. Today we are gathered here to learn his vast experience and deep knowledge in the field of dermatology and caring patient. I am confident that his talk will provide us invaluable insight. Thank you, sir, for continuous mentorship, for being a beacon of excellence in our field. We are eager to hear your valuable perspective on erbium glass and CO2 laser. Thank you, sir. Over to you, sir.
Thank you, Dharmendra. It's wonderful to see small plants which have grown into big trees now, giant trees. I had the occasion of having my session chaired by Dr. Rakesh John Avitas Prasad at Chennai, Mahabalipuram, just a week back. And now it's Dharmendra. Just goes to show that I'm probably reaching the stage where dinosaurs are. So I'll go to this talk, we will not lose. So I have a major masterclass coming in about 40 minutes from now, which is about half an hour, and everything you can possibly do with every device, which is operating in my clinic. But now I'll just make a short thing. Breaking the glass ceiling in scars from erbium glass to fractional carbon dioxide. So one of the things which is a go-to machine for me is a 1540 erbium glass, which targets the sebaceous glands, which in turn reduces the sebum production. And then you can see what happens. The 1540 mechanism is sebum reduction, and with the sebum reduction comes bacterial growth reduction. So the idea is to heat the sebaceous glands, get them atrophied, and temporarily arrest their sebaceous output. So what do we select? We select patients who have no topical responses, when isotretinoin is not an option, the immediate treatment, because a lot of them now say, Doc, it's Friday, I have a party on Sunday, can you do something? Eradication of resistant, localized, repetitive focus of acne. As you would have noticed in your clinics, there is one set of patients who get 1 or 2 large nodular acne lesions persistently on the same spot. I mean, they keep coming, they keep revisiting, and it's just in that area. This works well for that. So then the erbium glass uses, you can see it's excellent results. Obviously, I'm showing you the best patients, but so easy to use this, the 1540 erbium glass. Good results. And we'll skip through more of the pictures. And then fractional lasers. We've been through fractional lasers. I will not talk about it now. The idea is to produce small bridges of untouched skin, making the healing process go faster. This is the power of the carbon dioxide. We can see the ultrapulse. The whole idea is to get the energy in and out before it causes collateral damage to healthy surrounding tissue. And you can see this. So anything which is 0.6 mu and more is a risk to damaging surrounding tissue. So there you are. You can get significant improvement of scar reduction and erythema. So how many passes are the right passes? Fourth pass is the maximum you can give, because beyond the fourth pass, you're going to damage healthy tissue. Please remember that. It's the power of the pulse. And I showed this yesterday. Please be careful of the upper and lower eyelids. This is the comparison between the carbon dioxide and the erbium YAG. Always remember, large spot sizes, when you use any ablative device in your clinic, a large spot size requires high energy. So you see, as spot size increases, the volume of tissue destruction also increases. And the energy required to vaporize this also increases. So there you see the difference between the smaller spot sizes and the larger spot sizes. So selection of parameters, this is how it is. Remember, the epidermis and the papillary dermis. So where is the epidermis? From 0 to 150 microns. Where is the papillary dermis? 150 to 700 microns, where you have a lot of fibroblastic activity. There you go. So upper layers versus the papillary dermis. So spots density and spot sizes are important. Epidermis to papillary dermis, which is good for mild scars, lines, and the superficial rejuvenation of pigment and scar lines. So this is probably the best chart you can have. So exactly what is best, which problem. So when you see effective, it's green. So you look at CO2 and erbium, you can see 3 greens. Nowhere else will you see 3 greens. And you can see, therefore, choose the one which is best suited for your therapies. So patients must understand, a scar is a scar is a scar. You're never going to get rid of the scar 100%. You can only improve it to a considerable extent. So there you are. This is what I said earlier. So this is the key thing. You see, what is an ablative laser doing? See, you have heat, which stimulates new collagen formation. You then have the size of the fractional wound, and this is being used now for, first thing you need to know is that the optimal size should be 200 micrometers. Anything greater than 500 micrometers, you will have a problem because it can lead to scarring. So this is the current fractional wound size which is appreciated. Remember that now we use this for drug delivery, topical drug delivery, using of hyaluronic acid, use of tofacitinib, and then you can normalize the hypertrophic scars. So fractional CO2 in scars, you can see the enormous difference here. Before I do they have to exist all the options and come to you and say, we have tried everything, doc. Can you do anything else? Because fractional CO2 has a downtime, it could lead to PIH. So this is one of the patients. You have more patients coming your way here. Now, there are some patients who have soft, easy skins to work on, and then there are others who have rough, tough skin. These are scars which have been present for a long period of time. This is after one session, but you often need 3 sessions to such patients, because I would call this a leather. This is more than skin. This is leather. The difference between thick, tough skin, which is sclerotic because of a lot of scars. You can see the difference. Patients are pretty happy with this. These are the other ones. So the new mantra which I always use is, we used to teach that if there's active acne, do not do a fractional CO2. I now say if there is active acne, please go ahead and do the CO2. Because when you do a fractional CO2, it ruptures the scars in the dermis, which are trapping the sebum from coming out effectively. So because of the multiple scars of chronic acne, the sebum gets trapped in the dermis. It is not able to come out easily from the sebaceous gland, leads to inflammation because sebum is acidic and keeps giving you reddish nodules. So please break the skin, do the fractional CO2, and you'll see that once the tissue is reorganized and the scar tissue has been reorganized, sebum flows out freely, and therefore your chance of getting more acne becomes diminished. Burn scars are very important. This is an acid burn thrown by an enemy of his, and you can see, you may not think this is great, but patient thinks it's wonderful because he says, doctor, the color is better, my skin is softer, and I can stretch it, and I can open my mouth. So there you are. Burns, acid burn, and hot water burns in the kitchen, very typical. Fractional carbon dioxide with the fractional CO2 ultrapulse. Accident scars, you can see now, this is a patient who had multiple therapies in Dubai. She was involved in a road accident between Dubai and Abu Dhabi. Marcus did the fractional, we did the scar effects in this. Because the scar effects is the only fractional CO2 device which can go deep down to the 4 millimeters. So when you have a thick scar, this is the way to go to, and you can see what happened after 3 months and 1 session, and after 2 sessions, you can see how much flatter that thick sclerotic scar has become. That hypertrophic scar is now a very nice soft tissue. You just have to do the edges when she comes back. So there you are. The difference between then, 9 months ago, and now in a 16-year-old girl who's been through all other therapies earlier, and there was no use of steroid injections in this. Now this is before and after. So this is an astrologer who went to read somebody's horoscope, but he apparently didn't read his own. He had a road accident, the glass shattered, he had an accident, and he went to a plastic surgeon. The plastic surgeon did a good job, but the patient said, "Doctor, I feel there are grains of sand in my forehead." So it rang a bell. I said, there must be small bits of glass which no surgery can remove, which no plastic surgeon can remove. Please remember that. So I did this fractional CO2 with very high density of 20, medium power. I will not go into that because there are plenty of glass pieces came out. This is the example of a small glass piece. So when you get glass shatter injuries, irrespective of how good the job has been, if you see tiny little bumps in between the scar area, go ahead and do a fractional CO2 on that, you will be rewarded. So there you are, this is the patient, and then 6 months later, virtually normal. So this is another glass shatter injury with a small bit of glass came out before, after doing the ultrapulse twice, and then now after 7 months. more injuries. Please do not do the Q-switch laser immediately, because the Q-switch can lead to burns. You can do it as a last stage to remove the pigment which has come from coal tar. If they fall on a road and have an injury, there's not just an accident scar. Embedded inside the skin will be coal tar. There you are. So, all right, so I will finish well in time. So I always tell this to patients who come for cosmetology procedures. Do not seek professional help based only on charges. I always tell this to my patients because the doctor will have one go on your face. If the machine's second class and you are first class, the results will be second class. Over 5 years, you will be labeled as a second class cosmetologist. If you are second class and the machine is first class, over 5 years, you'll be labeled as a first class cosmetologist. So there you are. Use the best machines. And when you use the best machines, you'll always get the best results. So charges are not important in this. Thank you very much.
Thank you so much, sir. And with this, ladies and gentlemen, please put your hands together for all our chairperson. Meanwhile, I would also request Dr. Ramanjeet Singh, sir, to please come up on the stage and felicitate our chairperson. Sir, please stay back. Dr. Ganesh Bhai, sir, I would request you to please stay back and felicitate our speakers, our chairperson. Please put your hands together, ladies and gentlemen, as we are felicitating. Sir, you are the panelist in the next session, so I would request you to please settle down. And with this, ladies and gentlemen, we are felicitating Dr. Rupak. Please put your hands together for Dr. Rupak. Thank you so much, all the chairpersons who were present here. Thank you. And now moving ahead towards the next session, which is the panel discussion. And for that, I would like to request our moderator to please come up here on the stage. Our moderator for this session will be Dr. Ratnakar Shukla. Can we have a big round of applause for Dr. Ratnakar? Our esteemed panelists are requested to please join us here on the stage. Dr. Mohan, Dr. Suchna, Dr. Ganesh Pai is already present here, Dr. Vani and Dr. Asma Parveen. If you are present, please join us here on the stage.
Good afternoon, everyone. I am Dr. Ratnakar Shukla, and I would like to say thank you to Rana sir and Ramanjit sir for giving me an opportunity to be on the dais, where none other than living legend Dr. Ganesh Pai sir is panelist. So I am truly honored and blessed. So today we are going to discuss on the topic scar treatment in aesthetic dermatology. So I would like to take opinion from the panelist. What is a scar?
So basically, scar is any fibrous tissue that is caused either during the wound healing process or due to any trauma or injury.
Okay. Sir, would you like to say? Okay. So there are two quotes. Scar means the hurt is over, wound is closed, and healed done with. Scar can be defined as cutaneous scarring is a macroscopic disturbance of the normal structure and function of the skin architecture, manifesting itself as an elevated or depressed area with an alteration of skin texture, color, vascularity, nerve supply, and biomechanical properties. And it can present in various ways, as can be seen in this presentation. What is prevalence and impact on the quality of life when a patient or an individual have a scar on their body? I would like to take opinion from the esteemed panelist.
Again, this depends on various factors like genetic factors, racial factors, and many things, and depends on site, where the scar is. So if it is in the face, it will definitely have a very huge impact, even though scar is very minimum or small. If it is in the other body part, probably it may not be that much, so it completely depends on individual, how they perceive it.
Okay. Any other panelist would like?
It also depends on the age of the patient, the area where the injury has taken place. For instance, 80% of the problems patients have will be scars on the face or scars on the hands. Anything that can be covered with clothes is generally not such a major issue for people. And then if scar is in an area where it restricts movement, say the dorsum of the foot or the elbow region, that's when people are bothered about it, because there's a functional problem with that.
Yes.
So that's how it is. And then, okay, that's it.
Okay. So each year around 100 million people in the developed world acquire scars following elective surgery or surgery for the trauma. According to a study, 53.5% individual at least had a scar on their body. Most commonly locations were stomach and the face. The physical symptoms may include itching, stiffness, scar contracture, tenderness, and the pain. And the most common effect is psychosocial effect of unaesthetic scarring include diminished self-esteem, stigmatization, disruption of daily activities, and depression, anxiety, etc. Scarring can be classified as a fibrous tissue disorder, which can occur as a consequence of inflammatory and non-inflammatory process. And abnormal scarring is a well-known complication of wound healing. Let's discuss what are the types of the scar.
So there are various types of scar. There are different classification as well. The most common one is 2019 international classification, where it classifies as immature scar, mature scar, and hypertrophic linear scar, diffuse scar, then keloid, minor and major keloid. There is Japanese classification also, and there is different grading system of acne scar also.
I look at it in a different way because no point in seeing what the Japanese, Europeans, and the Americans do. Let's look at what we should be doing. In which case, I would say you look at the pliability of the scar. One of the first thing you need to see is the scar soft and pliable or is this hard? Because if you're going to a hard scar, then it's more difficult to remove. At the end of the day, you have to use a machine to flatten it. So if you have a hypertrophic scar or a keloid, then you're looking at a different problem. But the soft scar is much easier. Then look at the height of the scar. Well, that's very important. To bring it down to the level of the skin, it depends on the height of the scar. Then you see if it's erythematous or not. A young scar is always a pink scar. It's a developing scar. The next thing you need to know is whether the scar is tender, whether it's painful. Sometimes you can have a nerve trapped under the scar. Or sometimes the sensations of pain and burning can persist in some scars. So you've got to look at all these things, but I would consider, apart from the site where it is and the size, the pliability is the key. Most of us look at a scar without touching it. Please touch it, palpate it, see how it feels, try to lift it up and see whether it comes off freely. And then you have the answer whether you can use your tool of laser or not.
In addition, probably the color of the scar, sometimes depressed scar with hypopigmentation, depressed scar with hyperpigmentation. So color changes is also one of the important part we need to observe for the management point of view.
Yes, so scar can be classified in multiple ways, immature, mature, and here are the few, it can be flat scar, it can be raised scar, can be depressed, it can be fine line scar, can be keloidal, can be contracture, and can be stretch mark as well. This is type of acne scar. We all know it can be of ice pick, rolling, box, hypertrophic. The skin diagram showing how the skin looks in ice pick, rolling, and the box scar. Rolling has a band attached to deeper dermis. This is a pictures. Now, how to prevent a scar? I would like to take opinion from the esteemed panelists. How to prevent a scar if someone is planning some surgery or a patient present with the early trauma wound or something like this. So, how to prevent it?
For example, when this is a planned scar, planned surgical scar, the direction of incision matters most. We should always go for RSTL, go along the incision line should be along the RSTL. In the elliptical incision, there should be a proper ratio of width versus length. The length should be 3 times more than the width so that we can close it properly without much tension. So we should always go for undermining so that there will be minimum tension, and we can close in different layers so that the tension will be minimum on the surface. So dermal suturing is the most important one to avoid the tension. Eversion of the incision, while apposition, eversion of the ends are also important point to consider in the planned incision and surgeries. Post-care are also, intraoperative thing also very important to avoid infection, which is another important reason for bad scar. Similarly, post-care, especially antibiotic and all prophylactic things, and then early application of silicone in the gel form, sit form. These are again very important to avoid scar formation. Movement is very important if that is in the highly mobile area. I often suggest them, like if a patient undergo for any facial surgeries or something like that, I ask them not to chew very hard or like restrict the movement of facial expression for a few days. So probably these are the some ways how we can minimize the scar.
Okay. Any other panelist?
I just want to say that any scar, when it forms, it's just inevitable after surgery. The most important thing is let the scar be for the next 8 to 12 weeks. There is what I call practice what obstetricians do. Masterly inactivity. The baby comes out by itself, right? The gynec just stands there. It's the same way with scars. Have masterly activity for 8 weeks to 12 weeks because many of the scars will nicely regenerate themselves over 3 months. So you really don't need to do anything aggressive. But after 3 months, if you see that the scar is not acceptable, that means you have to next use either surgical procedures or laser devices to improve the skin further.
Okay.
There is something called scar modulation, like it occurs up to even 6 months to 1 year. So during the immature form, if we properly handle the scar, like proper massage, use of silicone gel, so that will also help for the better modulation of a scar. Suppose pressure application, if it is a keloid excision, then we can apply the pressure after the excision. So this thing also will help in the better scar remodeling.
Okay. So as rightly said, a good scar is a flat, thin, whitish and blended in with the surrounding skin, whereas a bad scar is a raised, discolored, widened, irregular or in a noticeable location. So one should have a plan and then take proper measures to decrease the scarring. Initial set of strategies to be established to minimize the risk of scar formation and is indicated before, during and immediately after surgery. In addition to optimal surgical management that include measures to reduce skin tension and to provide taping, hydration and UV protection of the early scar tissue. So these are the few measures which we can use to decrease the scar or can prevent scar. I would like to take opinion from the panelists about use of pressure garment, use of botulinum toxin, use of Steri-Strip, use of CO2 laser ablation and any other method.
Personally, after surgical treatment, clean surgical, like fresh surgery, I've never used this sort of modalities for the scar prevention. Yes, for like hypertrophic scar, keloid, and all these things, I go for these options. But for the prevention, I have never tried.
Okay.
So I do when there is need, that type of scar formation is already there, and then I go for. Otherwise, for the prevention, I have never tried these things. Only silicone gel I use topically.
So you use like pressure garment if there is a keloid on earlobe and you do a surgery. So whether pressure garment or pressure clips should be used or not?
Yes, yes. After that, I go for.
And what?
Even without any intervention also, I suggest. And after intervention, I always suggest.
Okay. And botulinum toxin, any role?
I have not. I have not used.
Patient selection is also important. Like if we anticipate this patient is going to has a keloidal tendency, then we should take these preventive measures early in advance. Okay. So otherwise, for normal clean surgery, if a surgical technique is very good, then we don't go for preventive option. I personally don't go for preventive option much.
Okay. So there are few studies which indicate that after doing even scar revision surgery, patient with the use of Botox has a better scar configuration compared to the patient or population where botulinum toxin is not used. Okay, moving ahead, any other method which you people can use for the preventing scar rather than this? Okay. So what are the treatment options once the scar is developed? Now a patient present with the scar, what are the treatment options? Few of the topical product is available in the market. Are you people using it? And if yes, how much improvement is there?
I use very oftenly. Immediately after suture removal, I suggest them to go with the silicone gel because these days patients are very concerned also. So they always ask for post care. So after suture removal, I go for silicone gel most commonly. And then for other option, depending on the outcome, as Sir has already highlighted, I ask them to wait for 3 months and then only I decide what to go ahead if there is need at all.
Okay. So I would ask, is there topicals have any role? Have you found that any greater amount of improvement in hypertrophic scar or keloid in patients who are using some allium-cepa, allantoin, heparin or such combination of the product?
Actually, it's very difficult to comment on because multiple factors are responsible for the scar formation. That's why I don't know whether this is just a placebo effect or it's really working. It's very difficult to comment on that part.
Yes, but it keeps the patient busy. You see, the patient wants to, they just can't sit and wait for 3 months saying, okay, it's going to work. So the sheer application of this allium-cepa, over a period of, twice a day for 3 months, even when the natural process of healing is going on, helps them to be committed to their therapy. And that's very important. And you call them every 4 weeks. The best thing to show a patient that he is improving is to take serial photographs. The day the surgery, the sutures have been removed, a month later, 2 months later, and 3 months later. So if you put those pictures up, patient will be very happy because he'll see the improvement. If you have no pictures at all, patient will be disappointed because several of these patients want 100% results. I mean, mentally, especially if they are software programmers. You see, if it's a vehicle or if it's a software program, it's 100 or 0. But in a medical field, it's an imperfect science. It's not a perfect science. So whether you're looking at blood pressure, diabetes, asthma, joint pain, migraine, anything else, I always ask the patient to look at the risk-benefit ratio. The benefit should be far more than the risk they take to improve the texture of their skin. And so if that works, then they're happy with whatever results they get.
Okay. And I would like to ask panelist that subcision, which method is more suitable or which method should be chosen, whether it is to be done by needle, by cannula, and now Taylor Liberator is another device which is used for the subcision. So any opinion for this?
No core needle does a good job. Even a Taylor Liberator does a good job. So if you're comfortable with the no core needle, that's great. Attach it to a 5 mm syringe and then, you can do it very comfortably. Okay. Taylor Liberator too. But at a certain point, we are treading on the toes of plastic surgeons. So it's very important for us to just put this one thing in our head. Okay, if it was my nephew, my niece, my daughter, my son, for this scar, would I send them to a good plastic surgeon or would I do it myself? If the answer is that I'd send it to a plastic surgeon, then send the patient to a plastic surgeon. Don't do it yourself because patients have full trust in us. And if we are not completely used to doing a lot of these procedures, then we may not get the correct results. So please remember that. Subcision is fine, we can do it. CO2 is fine, we can do it. But anything that needs surgical intervention, we better have some training on it before we go ahead and do it.
One thing I like to emphasize here is patient expectation is also very important. What kind of patient, what is the patient expectation? Because most of the patients who come to our clinic are well off and in the aesthetic clinic, and they have very high expectation, and they always ask me, will it go 100%? So there is nothing like, as sir said, 100%. When we do a surgery or when we do an excision, at least 50 to 80%, or when we do a scar revision, that is how we improve. So we should well in advance inform the patient about the possible outcome. So that is also very important.
Yeah, so proper counseling is a must. For keloid, I want to take opinion from the panelist whether they use only intralesional corticosteroid or in combination with 5-fluorouracil or triple combination with hyaluronidase, what they are preferring.
I generally prefer triple combination. Generally, the combination part will be 2:2:1. Okay. 2 part hyaluronidase, 2 part steroids, and 1 part 5-fluorouracil. Okay. So this is the most common formulation combination I go for. Sometimes, depending on the size of the scar, I can change. Size of the keloid, I can change. And along with fractional, if a patient is affording. This is the most commonly used.
Okay, so what are the benefit of using triple combination versus the only steroid one? Because it will add up cost to the patient.
Yes, but the cost is very minimum, first thing. And the side effect of corticosteroid, if you just go with corticosteroid alone, there will be telangiectasia just after 2 to 3 injections. However, the keloid will take like much more injection, many injections to have a desirable result. So these days, I always combine these 3 together.
My approach would be, if it is a small one, keloid, then I just give intralesional corticosteroid only. If it is a bulky one, like a big one, very fibrosed, then in such cases, the hyaluronidase will dissolve. It has a better spreadability, and this 5-fluorouracil also antifibrotic activity. So, in such cases, I combine all the therapies, triple combination.
Okay, fine. A few things we need to remember is some of these keloids have an overhang. It's something like a cave, and underneath this cave, you have a lot of, necrotic material, dirt, sebum, so that needs to be cleaned properly and thoroughly. The second thing is in male patients, many of the hairs which are very thick on the chest will prick the keloid constantly, and that becomes a stimulus for growth of the keloid. So hair removal with a laser should be done at least 3 centimeters surrounding the keloid. And the third thing for women is the necklace length should be shortened so that the necklace does not scrape the keloid, because that's another area we find that the keloid starts growing, especially in the women. This is an issue. So shorten the size of the chain, which is good news because you need less gold to do that.
Okay. So moving on, we will discuss the newer technology and the newer approach, and I would like to take opinion from the panelists about these techniques. Punch flotation, punch elevation, punch excision, and punch replacement grafting, especially for the acne scar cases. Tissue augmenting agent like booster, filler, biofiller, nano-fat grafting, dermal fat grafting for atrophic scar. What is your opinion of these newer technologies?
With the advent of like this lasers and other modalities like subcision and other things, because they are cheaper, I generally don't go for fillers and boosters. However, PRP I use very commonly. PRP and these days even GFC, along with microneedling or subcision, I use very commonly. Otherwise, this very new technology I have not tried. And also regarding the punch flotation, elevation, excision, all these older technology, I have never tried this.
Okay.
I've never tried this. But with the fractional and other modalities combined, I'm satisfied with those modalities.
Okay. Any other?
Combination, when you talk about acne scar, combination treatment is very important. So depending on the type of scar, if it is a deep ice pick scar or deep box scar greater than 3.5 mm, then we go with punch elevation, punch excision. Okay. Otherwise, ablative or non-ablative fractional lasers will do equally good. And some cases in deep box scar, we might need to do fat grafting or fillers as well. But yeah.
And what about intralesional RF or papular type of scar? Few rosacea patients have a papular scar over the nose, and sometimes vitiligo patient post-surgery comes with the cobblestoning and they have the papular scar. So how, I want to take opinion from panelists that how you take these such
Mostly,
cases.
even for the papular scars, I have used intralesional RF along with minimum amount of ILS.
Okay.
So I really cannot comment whether it's ILS working or intralesional RF working. I very frequently used to use intralesional RF before, but I could not find much difference with intralesional RF versus injectables. So slowly I started just sticking to the injectable, even for the smaller type of papular keloidal scars.
Any opinion for pinhole CO2 ablation for papular scar?
No, I have not done.
Yeah, we can put a monopolar, RF,
okay,
single needle into the papular lesion. That sort of settles it down. You can even do a CO2 at a very low power, but a monopolar RF will perhaps be better.
Okay. So we have a very limited number of time, so we quickly go through few cases. This is one acne scar cases and one more acne scar case. I would like to take opinion from the panelists, how they manage acne scar cases. This is a picture sent by Dr. Sushna ma'am to me. So, yes, opinion for management of acne scar cases.
First of all, we need to treat the active acne so that we prevent them from converting to macular and eventually converting to either atrophic or hypertrophic scars. So active acne treatment is very important. We should counsel that. And if there are not much active lesions and the active acne are under control, then we go for scar treatment. And it depends on what type of scar it is. Like.
Okay, so sir just now said in his lecture that even CO2 laser can be used for the active cases. So whether you people start invasive treatment over the active cases or you treat only with the topicals and oral?
Initially, I start with the medical treatment only. If the patients are not a good candidate, like a pregnant patients or who can't be prescribed on actives, then in such cases only I go for invasive. Otherwise, I usually start with the basics.
I have a half-hour masterclass coming up on lasers, so I'll discuss a lot of this because we're running out of time and I can't postpone my flight.
Okay, sure. So this is a atrophic acne scarring patient. Any opinion for this?
Probably I'd go for subcision first, followed by fractional laser, fractional CO2.
Okay. Why not scar excision and suturing?
Excision I prefer quite often, but if they are along the RSTL, I choose those type of depressed or elevated scar which is along the RSTL, I go for excision. If they are not, probably for the first two very small one, probably even excision would work better. But for the other one, it's a little bit bigger and not along the RSTL. So
okay. This case of stria, how you like to manage?
These are the kind of things. See, look, you're not going to get rid of this. Okay, this is important. What you can do is improve the texture of this. So when you do a fractional CO2, what happens is a whitish looking stretch mark, a pinkish white, will become brown. And that will begin to match with the surrounding skin. So the color restoration which comes with the irritation of a fractional CO2 can help this. Apart from this, we can do a 1540 or a 1565 resurfax. That also works very well for these kind of stretch marks. And then microneedling has been tried. Look, when a lot of therapies can be tried for any single problem, it means nothing is working well. Yeah, so basically you can go through the routine of using 1, 2, 3 different things, and generally patients, will improve over a period of time. But there is a propensity among, I think there's a lot to do with our racial propensity, because I have my classmates, my friends in the Gulf region. They say they have Arab women who are coming for the 7th delivery, 8th delivery, and no stretch mark. And our women seem to get multiple stretch marks even before they are pregnant. Yeah, it tends to be, there seems to be a racial and a genetic bias for this, because in our country, we see a lot of patients having stretch marks. Of course, it comes with PCOD and obesity, but even without that, we see that happening, and we see that after every delivery. But it doesn't seem to happen in the West Asian region to the way it happens here. This is an observation.
Okay. So this we already covered earlier, keloid and hypertrophic scar. Any such geographical scar, how you want to manage such cases?
For this type of scar, again, I would go for subcision followed by fractional and PRP in combination if available.
So there is a time limit, so we will conclude this panel discussion right now here only.
Thank you so much, sir. I would request you to please come at the center of the stage, and I would request our panelists to please felicitate Dr. Ratnakar. Ladies and gentlemen, please put your hands together as we are felicitating Dr. Ratnakar Shukla here on the stage. And I would also like to thank all the esteemed panelists who were here on the stage. Thank you so much, everyone. Now, moving ahead towards our next session, for that, I would like to invite our chairperson here on the stage. I would like to call Dr. S.N. Bhattacharya, Dr. Vijay Kumar Garg, Dr. Avnish Sharma, and Dr. A.L. Das. I would request all the chairperson to please join us here on the stage. Those of you who are present, please join us on the stage. And now with this, we are going to call our first speaker for this session to join us. And the speaker going to come up is Dr. Neha Gupta. Can we have a big round of applause for Dr. Neha Gupta? Meanwhile, I would request our chairperson to please introduce our speaker for this session.
A very good afternoon, everyone.
Dr. Neha Gupta, she is at present she is the director and dermatologist at which place?
So Dr. Neha Gupta is from Jabalpur. She runs her own clinic. She was former professor and HOD in that's not clear to me, I'm sorry.
Dr. Neha Gupta is the director and dermatologist at Dr. Neha's Skin, Hair and Laser Clinic, Jabalpur, Madhya Pradesh, India. And she has worked as ex-professor and HOD and now a well-known practicing dermatologist with more than 10 years of experience in clinical and aesthetic dermatology. She has also been a consultant dermatologist at Kaya Skin Clinic. She is a life member IDBL and SARC-AD and International Society of Dermatology. She has publications in national and international journals and has been awarded national and international certifications for expert training in acne, periorbital rejuvenation, melasma, trachology, fungal infection, and psoriasis. Okay?
Yes.
You are welcome, Dr. Neha.
Thank you so much, sir, for that wonderful introduction. I'd like to first extend my heartfelt thanks to Dr. Ramanjeet, sir, and Dr. Rana, sir, for extending their warm invitation and making me a part of this prestigious FADS. Now, before any further ado, jumping on to my topic, setting up a new aesthetic practice. These are some important decisions from my experience. First and foremost, we all have to ask ourselves, why is the need? So, in my opinion, this is a very important first sentence. You have to have an interest and passion towards aesthetics, for youthfulness, for self-image, for all things beauty. And that passion should be there. Of course, it gives you an independence. There's a one-to-one patient connect. There's an artistic fulfillment that you get. And there's obviously a greater earning potential, which comes only with experience. For all that, you have to first get qualified and trained, get your basics straight, both in theory and practical, get skilled, attend conferences like this, our very own FADS, attend workshops, fellowships, and augment your artistic and technical precision at every opportunity. Now, once you're trained, get licensed and certified. So you have a lot of regulatory and legal norms, especially in India. So you have to abide by that. These are non-negotiable. You have to have a medical council registration, a member at your dermatology association, like our very own IADVL, registration under the Clinical Establishment Act, license from your local corporation, agreement with the biomedical waste disposal agency. You can take a photograph of this if you want. A license from the State Pollution Control Board, professional and service tax registration, and if you have an attached pharmacy, so a pharmacy license. Now, once you've done all that, decide your location. Now, for that, do a market analysis, do that research for your space, finances, operational feasibility, and comfort. Your location should be an easily reachable one, preferably with a parking area. Be familiar with the hospitals, dermatology clinics, and other aesthetic centers. These are your potential competition. Once you've decided your location, decide your type of practice. Will it be a purely aesthetic practice, or a predominantly aesthetic, or an integrated one? This is by far the best approach. Now, coming to designing of your practice, of course, because it's an aesthetic practice, it should be aesthetic, welcoming, clean, and hygienic. You can always display your achievements and credentials on any wall. You can always loop in the media and procedures, the videos in the waiting room. There can be brochures, placards for patients. The staff is very important. They have to be well-groomed, greeting, knowledgeable, and proficient at client service. You should always give sufficient time for procedures, no rush or hustle in that. Now, once you've decided that, decide your target client. Will it be an exclusive clientele? This is the clientele coming from an affordable society with lots of connections, mostly aesthetic concerns. Or it's an everyday clientele with all clinical and aesthetic concerns. Now, why do you have to decide that? Because it's help in designing your practice, marketing and promotion, and of course, deciding your charges as well. Now, deciding your charges. Again, do your research and factor in the following: how much your colleagues are charging, the rates in your city. You cannot go way beyond or way less. The time that you're investing for each consultation, for procedures, the ROI, the time involved, the number of sessions in every procedure, the consumables used. And this is all for a static clinic. If you're traveling for work, do consider the time and distance of travel. And as our very respected Dr. Ganesh Pai sir said, remember, don't go cheap to attract patients. Now, once you've decided the charges, all that is done, decide your role. What are you going to do? Will you be the CEO or the medical director? Or you'll be performing your consultations, or other doctors will be doing that? You will be doing the procedures yourself, or will other doctors or junior staff will be doing? So this is again very important. Hiring the right team, be it the medical staff, the office management, the financial management, they all should be of high professional standards with a team-based approach, willingness to learn and adapt, and you can always provide them incentive programs as rewards. Now, all of that, what we've gone through, is of no use in this era if you don't do a little bit of publicity or promotion. You do not have to spend a fortune on that, but then you have to spend reasonably, be it website designing, marketing or advertisement, public relations, social media management, you have to be there. So hire experts in the field, follow medical board guidelines. Every information that you put on your social media should be ethical and accurate. You cannot just boast, and then when your patients come, they see otherwise. Not a good thing. Now, coming to an initial consultation, very important. You have to be actively listening to your patient. There should be a clear communication with a non-judgmental attitude. Set realistic expectations, very important. You can always do a skin and hair analysis. Give sufficient time to your patients. And preferably, in my opinion, you can always avoid procedure in the first session. This is not mandatory, but it always gives your patient some time to think and prepare and instill some trust in you. A regular follow-up is definitely important. Why this is important? Because this improves your learning and aesthetic judgment as well. It strengthens the relationship with your patient. So listen and address any signs of concerns or worries that your patient has. Coming to your tools. Use them wisely, choose them wisely. Again, do your research. This depends mostly on what your population demands, the demographics, the awareness, what your patients are really asking of you. You can always have pharmaceutical products. They can be in clinic or through an attached pharmacy. Now, when it comes to equipments like lasers or other things, always take support of your colleagues for finding out the proper vendors. What is the cost of the equipment, spares, and consumables? Ask about the trainings provided by the vendors. The credibility of the company of the equipment is very important. Ask about FDA approvals, the after-sales services, annual maintenance, warranties, and extended warranties take into account. Now, this is always a trick that you can follow if you're just starting with your first laser. Try renting it from an established colleague, and then you can see how your patients are taking it and before buying or investing in one. Now again, your tools are of no use if you are not insured. So take all these insurances into consideration: property damage insurance, equipment insurance, fire and burglary insurance. There's something called as a professional indemnity insurance, which I'm sure you must be having. But all things aside, a frank and truthful discussion with a patient during your consultations will avoid unnecessary litigations. But still, you need to be insured. Coming to preparing for the procedures, first you have to explain, give sufficient time, explain the details, alternatives, risks, complications, the outcomes expected, the duration of treatment, and the expenses involved. Take consent, start with the basic, gain that confidence, and then move on to the advanced ones. A few more slides. Photography, with the consent, a good standard photographs before and after pictures are very important. If you want to go in for publications, publishing your study or research, go for the DSLR or SLR cameras. And otherwise, there are very good mobile cameras also available now, but they are definitely not standardized. The positioning is important, a fixed anatomical position with a plain, non-reflective background, good broad daylight, or if it's in the evening, you can always put two lightings in the 45 degrees angle to the subject. There are also good imaging softwares which can be used for photographs. Now, we have to avoid complications, but sometimes they cannot be avoided. Now, for all that, remember, first, do no harm. Always undertreat your patients, treat conservatively, sympathetically, never ignore them, and see them frequently if they have any queries. Corrective treatment, if in case your complication arises, can be offered free of charge. Remember to have these patient records through a database or an EMR sheet can be available. There are online systems which are available now for booking and canceling your appointments, SMS reminders. These all keep the patient records in place. You remember that your client is everything. So build that reputation, build that strong relationship, because loyal patients lead to more referrals. Treat your existing patients well. This is really important because we keep focusing on new patients. You have to remember your old patients and your existing patients so that there's a good quality assurance that's maintained. Now, in conclusion, aesthetic practice is an art, a dedication. Nourish your interest in it. Set up a practice focused on excellent patient care, treating them with respect, dignity, compassion, and friendliness, providing stellar client service, giving them a great experience, but all under expert guidance. Now, the last, just remember these are myths, and these are your take-home messages. If I set up a clinic, they will come. If I buy it, they will come. If I charge less, they will come. If I offer more procedures, I'll earn more. If I keep adding cosmetic procedures, my practice will keep growing. I can do this all by myself, or I can be a silent partner. All these are myths. And before I fly back, thank you for your patient listening.
Thank you so much, Dr. Neha. I would request you to please step right at the center of the stage, and I would request one of the chairperson to please felicitate Dr. Neha Gupta. So as we are presenting this memento to Dr. Neha Gupta, I would request the doctors who are present here, please give a huge round of applause as we are felicitating. Now, ladies and gentlemen, also moving towards our next speaker of the day is Dr. Sanjeev Gulati. Can we have a big round of applause for Dr. Sanjeev Gulati? I would also request one of the chairperson to please introduce our next speaker, which is Dr. Sanjeev Gulati.
Dr. Sanjeev Gulati, I think, doesn't require any introduction. He is PG from JIPMA Pondicherry and senior consultant and aesthetics dermatologist, Bangalore. At present, he is there. He was formerly associate professor at Dayanand Sagar Medical Institute, Bangalore. Now it is at present he is there, and now he already his major achievements are he had this Pondicherry JIPMA degree. Then he has he's a winner of the charitable Ratan Award, that is from IMA Delhi branch in 2022. Best dermatologist, and he was the life member of FADS, then Pigmented Society of India, MA and IDAVS, IMA and IDAVS. Thank you, Doctor.
Thank you, Vijay sir and Bhattacharya sir. My seniors from JIPMA are here, so it's a real privilege for me to be standing here and giving this presentation. The topic is, it's a little different topic, medico-legal regulation and licensing for non-surgical cosmetics in India. So this is a topic we all should know about it a bit because it's important. So what is the definition of cosmetics? According to the Drugs and Cosmetics Act, cosmetics are defined as products intended for beautifying or altering appearance, which must be registered with the Central Licensing Authority prior to import or manufacture. And what are the licensing requirements? Manufacturers must obtain licenses from state authorities for Class A and Class B devices, while Class C and D devices require CDSCO licensing. I'll come to all of this a little bit. All cosmetics must comply with specifications outlined in the 9th schedule of the cosmetic rules. Professional oversight. The National Medical Council and professional associations like the Indian Association of Aesthetic Plastic Surgeons set ethical guidelines for aesthetic practices including non-surgical procedures. Legal framework. The Consumer Protection Act provides legal recourse for patients harmed by malpractice in cosmetic procedures. Medical professionals can be held liable under this act if they fail to meet established standards of care. So we are all covered under CPA, so we should be very much aware of all this. These regulations aim to ensure patient safety and promote ethical practices in the rapidly growing field of aesthetic medicine in India. So what is CDSCO? Central Drug Standard Control Organization. It is the national regulatory authority in India responsible for overseeing the safety, efficacy and quality of pharmaceuticals, medical devices and cosmetics. Operating under the Ministry of Health and Family Welfare, CDSCO plays a crucial role in maintaining public health standards through comprehensive regulation. Key features of CDSCO: regulatory authority, as we all know. It serves as the primary regulatory body for drugs, cosmetics and medical devices in India, akin to the FDA in United States. It ensures compliance with the Drugs and Cosmetics Act 1940 and related rules. Approval processes. The organization is responsible for approving new drugs and conducting clinical trials. It also oversees the import and registration of pharmaceuticals and medical devices, ensuring that they meet both local and international standards. Quality control. CDSCO establishes standards for drug quality and safety, conducts inspection of manufacturing facilities, and monitors post-market surveillance to ensure ongoing compliance with safety regulations. Divisional structures has it has several divisions focused on specific areas such as new drugs, biological products, medical devices and diagnostics, clinical trials, cosmetics, import and registration. Transparency and accountability. The organization emphasizes transparency in its operations by streamlining processes for online registration and documentation for manufacturers and importers. Public health focus. By regulating the healthcare products available in the market, CDSCO aims to protect public health, reduce risks associated with substandard drugs, and ensure that only safe and effective products are accessible to consumers. And believe me, this is a very big problem because a lot of spurious drugs are available in our market and we are constantly fighting about it. Overall, it plays a vital role in India's healthcare system by enforcing regulations and to safeguard public health while promoting high standards within the pharmaceutical and cosmetic industries. I hope this thing is achieved soon. So coming to the Drugs and Cosmetics Act 1940, is a comprehensive legal framework that regulates the import, manufacture, distribution and sale of drugs and cosmetics in India. What is a cosmetic? The Act defines cosmetic as any article intended to be applied to the human body for cleansing, beautifying, promoting attractiveness or altering appearance. Licensing requirements, like manufacturing license required for the production of cosmetics, manufacturers must apply to the state licensing authority using Form 31 and pay a fee of Rs 2,500 for the license and 1,000 for the inspection. Import license requiring for importing cosmetics into India, importers must apply using Form 42 and obtain a registration certificate from Central Licensing Authority. Standards and quality control, and of course, it goes without saying that the Act mandates that all cosmetics must comply with the specification prescribed under the 9th schedule or any other applicable standards. And regular inspection by drug inspectors are required to ensure compliance with these standards. Prohibition and penalties. The Act prohibits the manufacture and sale of misbranded or adulterated cosmetics. Violations can lead to severe penalties including imprisonment and fines also. Specialized courts are designated to handle offences related to the Act. Documentation and record keeping. Manufacturers are required to maintain records of production and sales, including details about ingredients used in cosmetic products. Importers must register each cosmetic product along with the pack size, variants and manufacturing promises before importation. Consumer protection. The Act includes provisions for consumer protection against unsafe or substandard products, allowing for testing and analysis by the government analysts. Some new cosmetic rules came in the year 2020. They were effective from December 15, 2020. Serves as a comprehensive regulatory framework for the manufacture, import and sale of cosmetics in India. The rules were established to streamline the existing regulations and ensure consumer safety and product quality. Key features. Definition of new cosmetics. See, a lot of new things have happened last 10 years, you know. So there was always a need for an act. New cosmetic defined as a product containing novel ingredients not previously recognized for use in cosmetics globally. Manufacturers can obtain prior approval from the Central Licensing Authority before manufacturing or importing such products. Licensing and registration. Manufacturers must apply for a manufacturing license using Form COS 5, while importers must use Form COS 1 to register their products. A single application can cover multiple cosmetics from the same manufacturer. The import registration certificate remains valid indefinitely, provided a retention fee is paid every 5 years. So this is also important for all the manufacturers. Application process for cosmetic license, quality control. All cosmetic products must meet specifications outlined in the 9th schedule. And of course, it includes mandatory declaration of all ingredients, even those below 1% concentration. You have to say what is there. The establishment of Central Cosmetics Laboratory is mandated to enhance quality control measures across the industry. Prohibitions. Importation of cosmetics is prohibited if they are banned in their country of origin or have a use before date of less than 6 months from import, contains certain harmful substances that have been tested on animals after November 12, 2014. So just a pictorial diagram. Determine the license type. Identify whether you need a manufacturing license or an import registration certificate. This is from the manufacturer end. Then prepare documentation. Application forms, COS 1 or COS 5 as the case may be. Safety data and efficacy test reports. Ingredient declarations and product labels. Manufacturing licenses and proof of compliance with good manufacturing practices. Online submission. Application must be submitted through CDSCO's online Sugam portal, which is a government site. Select the appropriate department, form type, fresh or endorsement, whatever the case may be. Fill in all the required details and upload the necessary documents. Pay the applicable fee through the Bharat Kosh online payment gateway. Inspection of the facility will be carried out by authorized inspector to ensure compliance with safety and quality standards. Application review. After submission, application will be reviewed by designated officer for compliance. If application is found satisfactory, it will be forwarded for approval. If discrepancies are found, they will be communicated to the applicant through the Sugam portal. Approval notification and then a registration certificate will be issued. The approval letter will be available in the applicant's Sugam dashboard. So, concluding the talk, the Drugs and Cosmetics Act 1940 and Cosmetic Rules 2020 establish a robust system for regulating cosmetics in India. Emphasis on consumer safety through stringent guidelines on product formulation and labeling. Clear responsibilities for manufacturers and importers to ensure compliance with safety standards to ensure accountability. They facilitate uniform practices across the cosmetic industry, mitigating risks associated with unregulated procedures. Detailed documentation and adherence to good manufacturing practices, GMP, required for both manufacturing and imported cosmetics. Aim is to enhance trust in cosmetic products through transparency and regulatory oversight. The rules play a critical role in safeguarding public health as demand for cosmetic products continues to rise rapidly. Thank you so much. If any questions, you can email.
Thank you so much, sir. Ladies and gentlemen, please put your hands together for Dr. Sanjeev Gulati. Can we have a big round of applause? Thank you so much, sir. So, ladies and gentlemen, we are about to call our next speaker. Okay, so we are going to call our next speaker of the day, and this is the master class on lasers by the genius. Ladies and gentlemen, please put your hands together for Dr. Ganesh Pai.
So Dr. Ganesh Pai needs no further introduction at all. And please give him a big round of applause for his generosity of spirit He has come to share his perspective and give us all a masterclass, share so many years of experience and all his learnings at no cost, I mean, with very little taking back, just except for applause. So give him extra applause.
Thank you. Thank you very much. Is the talk loaded, please? Okay, so it's not moving beyond this. Getting ready. Sorry? Okay. All right, so there you are. Oh, Yeah. Yeah, we just put this back to where it was. Oh God. I think you would have shut down and restarted this. All right. Okay. So, again the same problem. Yeah, I did the next one. Okay. So, the drive towards lifestyle dermatology is what is bringing us to our clinics every day. It's no longer about disease, it's about lifestyle now. I remember when we started in our 70s and early 80s, people used to come from other specialities and tell us, what do you have anyway? If you have a dry lesion, you wet it. If you have a wet lesion, you dry it. Either you have a choice between salicylic acid or betanoate. So why have you taken this specialty? This is the way things used to go because there was hardly any treatment available. Diseases could hardly be properly treated. But this is the same time when radiologists were called photographers, remember. And you can see, and orthopedics did not exist in the mid-70s. And now, when you look at it, these are the best three lines which are going: radiology, dermatology, and orthopedics. So, the drive is towards hair removal versus hair reduction, skin rejuvenation, acne control, scar effacement, and pigment amelioration. So, most of the work that we are doing here, which would be non-surgical, would be in these five. And so everything that you do is to modify your existing defects, because this is the concept for beauty. Botox for wrinkles, lipolysis for fat reduction, CO2, hair removal lasers. It's come to the point that you have, and this is really a sad thing, that women are coming into the clinic, or men, more women. They have flaming thyroid issues, they have obesity, they have diabetes, but they are not as concerned about that because Dr. Saab kuch dikhta nahi hai wo, as the wrinkles on their face. So the wrinkles are taking priority over systemic diseases among many of these people because they should look good for the next kitty party. So in today's world, people are living longer. Older people want to feel well and look good, which means keeping fit and healthy, preventing wrinkles, removing pigmentation, and continuing to give lectures on stages like this well past the age of 70. So we'll talk about bit by bit about the lasers. You have the Q-switch lasers, the common indications being tattoos, freckles, nevus of aorta, caphalomicules. So until recently, the nano Q-switch lasers were the gold standard. And if you have a substantial practice of pigment laser, then I think it's about time you graduate to the pico, because the pico lasers are a superior modality of treatment, but they're very high powered and must be used judiciously to prevent burns. So these are the sort of nano Q-switch influences of laser device, Q-switch devices, which are high powered. They can deliver large energies, as you can see that, and they can use them in different modes. You can use them on the PDP mode, which is the pulse type pulse, or the quasi mode. And you can see that you can use different modes to improve the end result on the patient. So you have the 1064, you have the PDP mode, you have the 532, and you have the quasi mode. And then you have the MLA handpieces. Now, it's very interesting. If you have a nano Q switch laser, you can ask your distributor to elevate it by using an MLA handpiece, which is a micro lens array handpiece. The MLA handpiece focuses the energy in the center, vis-a-vis being diffuse. And so if it's virtually works out as half a pico machine. So if you ask your device man, do you have an MLA? Most of them have. You can upgrade by using an MLA. So with this MLA handpiece micro lens array, you can see you can get reasonably good results for this kind of diffuse pigmentation. And after 2 sessions of this, and even with the nano Q switch laser, you can do a reasonably good job if you have a melasma which has been chronic. I mean, young melasmas, fresh melasmas in younger patients, which are unstable and continue to expand, continue to increase, are not very good candidates for your Q switch lasers. But if there's a 50, 55-year-old with a melasma which has been around for a long period of time, you can attempt to do a Q switch laser, the laser toning. And so what's the difference between a nano and a pico? Essentially, the nano is breaking down a rock to the size of a pebble. And the pico is breaking it down from the pebble to sand. Now the pico Q switch has 532 and 1064. And you can see that it's well absorbed. So what is it that is required to convert a machine to pico? Because these nano lasers cost around 20-25 lakhs. The picos start around 60 lakhs to 70 lakhs. But I'll tell you why it's worth it as we go along. If you have a big practice of pigment or acne, my go-to machine now is the pico. So they do what's called mode locking, which is the non-linear effect of Q-switched crystals are stimulated inside the resonator to create faster pulses. Okay, so you do what a technique called mode locking to create faster pulses, because in pico you need faster pulses. Now, what is the time? See, this is where it's very important to you clinically. What is the time duration between a pico and nano sessions in tattoo removal? You can use a pico every 15 days for a tattoo, whereas a nano you would need 45 to 60 days. And why does it happen? Because it does not need high energy levels. So you can, when you use a pico, you can use a low power. And you can use a low power because the power is energy by pulse duration. See, pulse duration of a pico is 10 to the power of minus 12. Nano is 10 to the power of minus 9. So when it's 10 to the power of minus 12, the pulse duration is very short. It gets in and gets out very quickly. So since that is the denominator, to get a higher power, and this is physics, you don't need much energy. Which is why when you use a pico, you can use it on a lower energy, and that will make sure that you do not do collateral damage to surrounding tissue. Tattoo removal with this. So what is the pulse range of pico Q switch lasers? If you're buying a pico, this is where it is, 375 to 760 PS, picoseconds. All these lasers are operating between these energies. And so how do picosecond lasers work? They generate a very high peak power, making it the photomechanical fragmentation of the tissue much more efficient. So you do a photomechanical fragmentation. And this is my go-to machine. And among the 14 different technologies I have in my center, I have been using pico more and more for inflammatory acne along. So if I have deep scarring, I would go to my fractional CO2. But if I have active acne with moderate scarring to superficial scarring, I'd go and do the pico Q switch laser because it creates something called LIOB, laser-induced optical breakdown. This laser-induced optical breakdown leads to regeneration of collagen by stimulating the fibroblasts to lay down new collagen. and therefore you get nice, beautiful skin. We have lots of patients for this every day, and if you have a busy acne clinic, the Pico laser is a great machine. It will do your acne, it will do your acne scars, it will do your tattoos, it will do your melasmas, it will do your laser toning, it will do virtually everything you need to do. So, okay. Now, more of the same with Pico for acne. So the criterion for using the Pico is, it's very powerful. It's like a Ferrari, huge engine power. So please don't step on the gas straight away. When the hand place is not firm, you can cause laser-induced optic breakdown. Now this is a lady who had nevus of aorta, for which she had had multiple treatments with the nano laser earlier. She came, I did. See, this is one of my first cases of Pico. So I overdid it. This is wrong. I should have used, because I didn't use the physics formula, that the energy I used should have been much less compared to what I used. So you saw Leo. This is laser-induced optic breakdown. It is necessary, but it does not have to be so obvious. Never mind that, still the patient became very good. And you can see after 5 sessions of Pico, this patient who had failed on a nano Q-switch laser for her nevus of aorta has virtually, she's a lady doctor from the Northeast, was doing her medicine in one of the medical colleges in Mangalore. So Pico is a great laser for nevus of aorta. You can use Pico lasers in freckles too. Very nice results. Again, the Leo, one of my older patients. But you will find some amount of Leo irrespective of what you do there because of the nature of the machine. And you can see good results with this patients. So what is the complication you can get, especially in patients who have freckles? And especially in patients who have blonde hair or light hair, you can see hypopigmentation. So this is a risk you must explain to your patients when you do it. And it's higher in dark-skinned patients, and I will show you this. Look, the patient developed lesions like this. Immediately after doing the freckles, there was spots of hypopigmentation, actually bordering on depigmentation. But you reassure the patient that the color will come back. Here's another patient. She improved after 2 months, and after 4 months when she came, she was perfectly fine. Here's another patient I just done about 10 days back. She just wanted the central area of her face done first. You can see that she had auburn hair, blonde hair, and she has developed depigmentation. But 2 or 3 months from now, the pigment would have come back. So there you are. So summary, picosecond lasers have a pulse duration much shorter than nano. It matches the stress relaxation time for tattoos. They have excellent responses. So where would you use what? See, when you use pigmented nevi and moderate acne scarring, Pico lasers are very superior. They are the go-to machines. Melasma and freckles, you have similar results, but melasma, stable melasma tends to do very well. And in tattoos, you can have virtual total removal. But the most important thing that Pico lasers are doing, they are not doing just the superficial things. They are remodeling the collagen. That is why, to my pleasant surprise, I found a lot of the moderate and superficial acne scars virtually disappeared. So you can remodel the tissue and achieve results which you normally achieve with fractional carbon dioxide or erbium by using a Pico Q switched. So fractional microneedle therapy, which is people who have virtually no time will not come and do a fractional CO2 with you because you need 4 days or 5 days before the patient improves. So you do MNRF, which delivers energy to both the epidermis and dermis through insulated needles. You can have 2-in-1 radio RF systems. Please use a dual shot feature. Some of the microneedling RF machines which are coming in new, they release the energy at 2 points in the needle. So at the upper dermis and the lower dermis. So don't use one where you have single release. Choose one which has dual depth double shot feature. And this is especially good for the lower eyelids and the double chin. So these are the standard features of most machines which are dual shot. They will always have a vacuum to pull the skin up with these features, and the easily changeable drips. And you have multiple pins. So you have manual, auto, mono. You want to do a single syringoma, you can use a mono. You can do a 25 pin for acne. You can do a 49 pin if you would like to use topical therapies as drug-assisted drug delivery, especially when you're doing application of peptides on the scalp. So this is, you can achieve with the MNRF. Reasonably good results, but not as good as the PICO or the fractional CO2. You can do a PRP with MNRF 3 sessions. Reasonably good results. Very happy patients. So a lot of you youngsters ask, so what's the difference between an RF machine and a HIFU? Well, this is it. The radio frequency is for skin tightening. The HIFU is for skin lifting. The RF is for wrinkle and right-eyed reduction. The HIFU is for fractional lipolysis. RF can reduce the open pores. HIFU can use eyebrow lifting. So skin texture improvement happens with the RF. You can get submental lift. So HIFU is lift, 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 lift. It lifts up everything. Radio frequency does the other thing. So you need a combination of both ideally. And so RF versus HIFU, you can look at this difference between the temperature, depth, and precision. You can see the RF is using temperature less than 55 degrees, and the HIFU is using 60 to 70 degrees, where you're actually denaturing the collagen, which you're not doing with the RF. The depth, you can have a look. RF is much lower, less than 3 mm. The HIFU goes 4.53 and 1.5 mm. The precision, HIFU is highly precise. So actually you can use your HIFU and Botox, you can get brilliant results. So you can see the difference in this picture. Take a shot if you want to know more. And so this is the difference in the depth. You can see the comparisons. You can go with HIFU to different depths. All right, so the mechanism of HIFU is coagulation necrosis and maintaining temperatures up to 60, and then acoustic cavitation. See, use a HIFU, you can see good results, you can see the lifting of the skin taking place. And then you have the nanofractional radio frequency, and how does this work? This is how it works. Because of the different layers of skin having different conductivity. And the electricity will always look for the path of least resistance to get out. So you're essentially causing micro wounds, and with these micro wounds, with these high temperatures, you are going to get stem cells, the surrounding skin stem cells start producing heat shock proteins. This is for acne. But they're not as good as using a PICO for acne, or as good as using fractional CO2 for scars. Then you have the erbium glass, which I talked to you about. I showed this in my previous talk, the erbium glass. And then you have the ablative erbium 2940. The erbium is a very gentle laser. It removes 50 microns at a time. Every shot, every pass makes it 50 microns. So you effectively need 3 passes to go to the dermoepidermal junction. At that point, the water interface takes place. The fluids come out from the dermoepidermal junction, and then the erbium is no longer as effective. You can remove nevi with this. Though CO2 would perhaps do a better job. And you can use pixelated lasers. So patients who have this kind of skin, chronic weather-beaten look, farmers, people who have a lot of outdoor activities do very well with the use of the erbium laser. You pixelate and remove it, and you can see very good results. Use a dye VL wavelength of 500 to 600 nanometers. You can see how patients improve with this too, including those with rosacea. Then you come to the fractional carbon dioxide laser. The gold standard of the fractional carbon dioxide laser is the fractional CO2 ultrapulse from Lumenis, which is the only laser which can go to a depth of 4 millimeters. So you can tackle hypertrophic scars and you can also tackle keloids with this. Same picture again which I showed you. I showed this picture too earlier. Difference on these wavelengths. See the spot sizes. These are important for you. Use larger spot sizes because then the energy is, you need more energy which this machine will provide you. And the energy also vaporizes the tissue, which is very important. And the selection of parameters, always remember 0 to 150 is the epidermis. So 3 passes of 50 microns each is the erbium. And 150 to 700 is the papillary dermis. This is where, this is the game changer area because this is where you have the fibroblasts and lots of metabolic activity taking place. So when you damage this tissue which is full of scars, you are stimulating the fibroblast to lay down new collagen. That's how you get good smooth skin. So spot size and density matter. I put this picture earlier too in case some of you were not here. Green is effective, so when you look at the CO2 laser, except doing ice pick scars, it virtually does everything else. The rolling scars, the shallow box scars, the deep scars, all of these are well managed. And if you look at PRP underneath, you can see it hardly does anything, ineffective it is. So this is the erbium and fractional CO2 lasers paper which I published in the Journal of Dermatology and Plastic Surgery. And then one more which was the fractional CO2 which I showed the other time, where the mantra is no matter how good a plastic surgeon you are, once the surgery is over, if there are tiny papillar lesions within the scar, if there's a glass shatter injury, it means there are tiny bits of glass in the skin. So do a fractional CO2 carpeting. You carpet the skin with the fractional CO2 and you will see these tiny little glass pieces coming out. And then you have before and after of fractional CO2 here. The machines to go. So even if you have inflammatory active acne, fractional CO2 is great. There you are. And now what I have been doing is application of I do a mild fractional CO2 and apply tofacitinib cream. So this is the best way of laser-assisted drug delivery. You're giving oral tofacitinib for vitiligo. What you do for the skin, especially on the face, eyelids and face, and it works very well, is you do a fractional CO2 at a low power, but a high density so that the skin is well damaged, abraded, and then you start application of tofacitinib gel with UV light, which is natural sunlight will do, and patients come with significant improvement in their vitiligo. So please use tofacitinib gel or ointment post doing a fractional CO2 because you're doing laser-assisted drug delivery. And the moment you do the procedure, don't apply any antibiotic cream. Start with tofacitinib gel. There is no saying we'll wait 1 week for the skin to heal. We don't want the skin to heal. We want the tofacitinib to get in before the wounds start to heal. So very nice for using tofacitinib. Then I showed this too for acne, for accident scars. Fractional CO2 does a great job when you're having thick scars. You can see how dramatic the improvement is, how tense and thick the scar was earlier. Keloids, which we do. And then the 1565 fiber laser, which accompanies, it's a good accompaniment for a fractional to CO2. Lumenis has this too. And 1565 fiber laser can be used, all sorts of shapes. But the important thing about that is that it heats only up to the mid-reticular dermis. So when you're heating only up to the mid-reticular dermis, it's very safe, serves as the stimulus for inflammatory mediator release and fibroblast activation. You can see how this works too. Virtually every device can be used to work on acne and acne scars, depending on which machines you have, providing you know how to use them. Then you have the intense pulse lights, IPL technologies. Most people do not use an IPL, but IPL has its own story. It can do very well, especially with inflammatory acne, pigmented lesions, as well as for erythema. So the IPL has 9 filters. It's very simple. You use the filter to cut off the other wavelengths and show the wavelength, shine the wavelength that you need. So this is how it is, the IPL component. You have a filter, it cuts off the undesired wavelength, gives you exactly the wavelength you want. So this is one of those, just about 2 sessions, a nevus, vascular nevus on the nose, which is beginning to blunt and improve. A nevus which has been done with the IPL, because the patient wanted an IPL, also shows improvement. And you can look at this, how an IPL done underneath the IPL, which has been done on the lower eyelids, has dramatically cleared the dark circles. I never expected this to happen because I've been handling the IPL only for the last few months. Just to try out how things work, and 3 patients now where the under eye dark circles, the patient has shown dramatic improvement, which is not so true for pigment elsewhere on the face. So these are skin tightening can be done, and controlled cooling using Peltier, many devices now with focused electromagnetic waves. Again, basically you are stimulating type 1 and type 3 collagen. You can see the difference here. You can see the skin tightening. Better skin, laxity is gone, including the under eye, this thing. Then you have a long pulse Nd:YAG, which I do not use anymore. This is vital for port wine stains, leg veins, telangiectasias. But I use them a lot for warts now because they tend to get rid of warts very effectively with a couple of shots. Nevi can also be removed. Then you have combination wavelength in laser hair removal. This is important now. On a basic level, if you don't have a high-end laboratory, please remember the middle thing. When do you suspect the polycystic ovary disease? When there's a mildly increased testosterone level or an LH by FSH ratio of higher than 2:3. So LH divided by FSH should be more than 0.66. On the 5th day of the menstrual cycle, so the patient draws blood on the 5th day of the menstrual cycle, this, if you see it's more than 0.66, then you are probably looking at an early polycystic ovary disease. Frank polycystic is easy to know. But when they come with developing polycystic ovary and you start doing the hair removal laser and it doesn't work after 6 months, this is the reason. You're probably starting to treat. So if you start doing hair removal on a patient and after 4 to 6 sessions you don't see much improvement, it's probably because you are treating the showroom without treating the go down. The simple thing is that the ovaries are continuing to produce a lot of hormones, testosterone, a lot of LH, and therefore you need them to go to not a gynecologist but an endocrinologist. Please remember that. Because gynecs, instead of addressing the problem, will tend to talk them out of doing the hair removal. I have seen a lot of gynecologists, unless they themselves own a hair removal machine, then your patient is unlikely to come back. Please remember that. So look at ovarian tumors on one side and look at the other side as congenital adrenal hyperplasia. You should be a physician first too. So this is the difference between single wavelength and triple wavelength. With its benefits, remember, the single wavelengths are much more painful, more likely to cause burns. The triple wavelengths are much more effective, much less damage, much more comfortable. Because the 2 things women ask you when they come for hair removal is, doctor, is this painful? We said no. And said, the doctor, is this expensive? Both of them can be answered by you. And this is the hair growth cycle. These are the wavelengths with, you have 755, 810, 1064. You also have the 1064, 940 and 810. So you have various combinations going now for hair removal. I produced a paper which is just about to finish, which is the efficacy of high repetition versus this thing. Essentially, I was trying single wavelength versus multiple wavelengths, and we found that results are pretty good with both, except that the chances of burns were more with the single wavelength. What not to laser is very simple. These familial pigment lines, patients who have obesity as an issue, patients who have dark skin, very dark skin. Okay. So the last slide is, Edison fell in love with invention, Ford fell in love with motor cars, Kettering fell in love with research, Wright brothers fell in love with aeroplanes, Luther Burbank fell in love with plants, and you must fall in love with your lasers, because when you do this, you'll have a wonderful life ahead, because these are lovely machines to work with. They are toys. Once you begin to like them, you can use them as expensive toys to create exactly the structure, the therapy, the treatment schedules to get the best results out of it. Thank you very much.
Thank you, sir. May we have a bigger round of applause? Thank you, sir, for helping the audience reinforce their dreams. Thank you so much.
Thank you so much, sir. And I believe that was one of the most informative presentation that has been delivered. Thank you so much, sir. And for meanwhile, I would also request Dr. Ramanjeet Singh, sir, to please come up here on the stage to felicitate our chairperson. So the first chairperson whom we are felicitating is Dr. Avnish Sharma. Ladies and gentlemen, please put your hands together as we are felicitating our chairperson, Dr. Avnish Sharma. Next, we are going to felicitate Dr. Vijay Kumar Garg. Can we have a big round of applause for Dr. Vijay Kumar Garg? Dr. S.N. Bhattacharya. Can we have a big round of applause as we felicitate Dr. S.N. Bhattacharya? Thank you so much, sir. Now, ladies and gentlemen, we are going to present our next speaker here, and he's coming up with a presentation from Spectre Medical, talking about the next generation HIFU. Here we're presenting Dr. Ratnakar Shukla on the stage. Can we have a big round of applause for Dr. Ratnakar? Okay, so we are going to present Henna here on the stage, Miss Henna from Spectre Medical.
It's working. Okay. Good afternoon, doctors. My name is Hannah. I represent Spectra Medicals. A while back, I was talking to one of my doctor friend, and I asked them, like, what laser, hair removal do you like personally? And she said, I like Candela. And I'd say, what about like Q-switch laser? And she said, Photona. So we know one company cannot have all the multiple good products. So multiple company have good products, and we thought, why not bring those product to India? So with this same vision in 2005, So in the same vision in 2005, we brought Spectra Medical to India. So Spectra Medical is launched by Mr. Ramamurthy and Mr. Prabhakaran. So we started the company with 3 products, Mesoaesthetics, Canfield and Thermage in 2005. By the end of 2024, now we have launched more than 28 companies in India. We have offices all over India with the 4 headquarters. The headquarters is in Chennai. We have introduced 4 new offices in India, Hyderabad, Bangalore, Cochin and Delhi in this years. And I'm going to give you a little brief about the product portfolio we have with Spectra Medicals. The first is Mesoaesthetics. So Mesoaesthetic, we have monosubstance peel, combination professional peels for your acne problem, pigmentation, anti-aging and rejuvenation. Then we have mesotherapy products also, MCT injector for your PRP or for carboxy treatment. And then we have M-Pen, which is a microneedling. We have introduced NTRG also. NTRG is basically a first human bone marrow derived stem cell growth factors, which we have introduced this year in India. It's from US. We have introduced Obagi Medicals also. Obagi Medicals basically have a great, skin care product, which is already available in 60 countries, and now it's again available in India as well. We have Circadia Booster also for anti-aging and for hydration, which we can use with HydraFacial. So now coming to the laser and energy-based device category, we have, this is a laser hair removal category where we have different products, because usually every doctor sometimes they prefer single wavelength, some doctor prefer like double wavelength, some prefer triple wavelength. So
limitless possibilities with selective JAK1 inhibitor. फिर नहीं होगा, ओके, नहीं हो रहा बेटा, अच्छा ओके ठीक है. अच्छा इधर करना, ओके ठीक है ठीक है. So the flow of the talk would be atopic dermatitis, introduction of abrocitinib, JAD1 mono 1 and 2 clinical trials, safety profile of abrocitinib, and patients, which patients are most potential, with summary and conclusions. Chronic relapsing remitting disease characterized by intense pruritus and eczematous lesions form the mainstay of atopic dermatitis. There may be erythema, excoriations, induration, lichenification of the skin. Most of the patients, they suffer with the commonest symptom, which is itch in case of atopic dermatitis. About 98% of the patients, they complain of itch, which may be more during daytime or nighttime also, which will hamper their work and everything. So coming to the pathogenesis, there are two hypotheses. One is inside out and the other one is outside in. Inside out, there's imbalance in the T subsets with Th2 cells predominating the production of type 2 cytokines, which further leads to the activation of IL-4, 5 and IL-13 cytokines, and these results in sensitization and allergic inflammation and secondary epithelial barrier disruption. Whereafter the epidermal barrier disruption further leads to atopic dermatitis flare, and there is outside thin. Once the barrier is disrupted, outer pathogens, they start invading and giving all sorts of problems, thereby giving a flare of atopic dermatitis. So barrier disruption, itch, inflammation, and then susceptibility to skin infection, lichenification, all these form, and they contribute to the dysregulated process. And these are various cytokines which are activated during this process. So I've already told you interleukin 4, 13, 22, 31 and interferon gamma are the main signaling pathways which form the mainstay of atopic dermatitis. So coming to the guidelines, various guidelines have been proposed according to the severity of the disease. In mild to severe forms, there may be optimized topical therapy for inflamed areas. There may be you can use topical steroids, topical calcineurin inhibitors, crisaborole ointments, or wet dressings. Now, moderate to severe patients, we need to use systemic therapies, phototherapies, biologics, dupilumab, which was very, very commonly used before starting this drug. Then there are JAK inhibitors, upadacitinib, abrocitinib and baricitinib, and then there would be immunosuppressants, which everybody is using these days. So there were a lot of gaps while treating atopic dermatitis. Mainstay therapies pose limitations for long-term use. Topical or oral medicines were preferred over injectables, and higher pill barrier burden and frequency of the medication again interferes with the compliance. These were some of the serious lapses which we used to come across while treating atopic dermatitis. Abrocitinib in India is indicated for the treatment of adults with refractory moderate to severe atopic dermatitis whose disease is not adequately controlled with other systemic drugs. So this is a newer molecule. I have certainly tried on 3 of my patients with wonderful results. The JAK and STAT pathway is believed to be important mediator in the pathophysiology. So abrocitinib, which is very, very specific with JAK1, it acts only on JAK1, so it doesn't block other cytokines. So it is a good molecule which works very, very fast and has shown tremendous results. So the clinical program, various clinical studies were done before introducing this molecule. So JAD 1, 2 and JAD mono, JAD 2, JAD regime, these were some of the studies, and then there is JAD extended studies which is still going on, which needs to be completion. These studies were done in about 3,000 patients with moderate to severe form of atopic dermatitis, and various range of their efficacy and safety endpoints were noted. So JADE Mono 1 and 2, two identical design phase 3 randomized double-blind placebo-controlled 12-week trials evaluated the efficacy and safety of abrocitinib. So according to the studies, the screening period was for about 28 days earlier, then it was noted at 12 weeks, and further studies are still on. Abrocitinib 200 milligram monotherapy once daily is supposed to be gold standard, what they claim for treating atopic dermatitis adult patients. Abrocitinib 100 milligram monotherapy also has been done, and they were compared along with placebo studies. It was noted that the IGA score in moderate and about 59.2% was achieved, and in severe patients about 40.8% was achieved while treating the patients with abrocitinib. This study again shows 200 milligram was way superior than results with 100 milligram, and obviously from placebo studies. In JADE Mono 1 and Mono 2, again these studies were quite promising with 200 milligram of abrocitinib. Further clearance with abrocitinib monotherapy again showed promising results. In about 43% of the patients, they started clearing the lesions from very week 2, and they cleared in about 3 months of time. So these were some of the clearance of the lesions with abrocitinib, baseline week 12, and then these study they included for week 12. So very, very promising results. And first symptom which improved was the itch, which started improving right from day 2. That's what they claim, and that's what even I have found in my patients. They started showing some sort of improvement. So the clinically meaningful response, abrocitinib monotherapy or 200 milligram once daily significantly improved the signs and symptoms of itch, and duration response was significant. It started with as early as week 2 and continued until week 12. Speed of itch reduction 1 day after treatment initiation, and reduction in pruritus in severity was measured by NRS4 and was observed and continued for week 12 and the response that we achieved after giving abrocitinib, it was sustained. This was very good point when we were treating with abrocitinib. So, however, very few side effects were seen. They were very, very mild. The side effects were noted in the form of nausea and narophagitis, which was main, and it was certainly reversible. And headache also was there, but it wasn't persisting for a very long time, and plain paracetamol could take care of this. Now, lab investigations were at par when we were treating patients with other biologics, when we used to start biologics. Similar investigations were done, and they were all recorded at baseline, then week 4 it was done, and then after that every 4 months repeated. Abrocitinib was well tolerated, showed acceptable safety profile. Most frequently nausea, headache or acne were noticed. The rate of treatment discontinuation was very less because of these side effects, and dose-related decrease in median platelet count was observed at week 4, but however it was reversible. So some of the contraindications: pregnancy, absolutely no. Then breastfeeding also, abrocitinib is contraindicated. And fertility, based on the trials, it was reversible after 1 month, so 1 month contraception was required. Serious infections, when we talk about it, abrocitinib should not be started. Live vaccine should not be given, and in patients with tuberculosis or viral reactivation, has been reported but very few cases. Dosing 200 milligram is the standard dose. To initially begin with, 200 milligram is a good dose. Then you can, once lesions are cleared, itching is reduced, you can definitely reduce the dose, and maintenance can be kept at 100 milligram per day. So not much of interactions have been noticed. Only some patients with hepatic or renal impairment, you just need to decrease the dose, and once your symptoms are fine, you can continue with that decreased dose. Screening I've already told you, and I think that should be fine. So thank you very much for your patient hearing. Thank you. Thank you.
Thank you so much, sir. And now I would like to call here on the stage Dr. Ganesh Pai, sir, along with the Luminous team. So I would request you to please come up here on the stage. Meanwhile, I would like to tell you that the lunch is open, and if you wish to proceed for it, you may.
Good afternoon, everyone. My name is Navdeep, and I head Luminous in this country. And I'm so lucky that we have Dr. Ganesh Pai with us, who has been using our machines for more than 2 decades. You have been listening to him. So today I take this opportunity to thank him. I thank Dr. Jyotirmay Bharti, Dr. Rana to give us opportunity. And we are happy to reintroduce our Stellar M22, because this is one machine which has multiple application platform with 4 technologies, that is IPL, Resurfix, NDAG, and Q-switch, and that differentiates the practice of dermats, plastic surgeons from the quacks, because the indications that it can help a dermat do, no other non-doctor can do. So cutting it short, I proudly say Luminous has legacy of 50 years. So we proudly say that we invented IPL, we invented CO2, we invented diode, we have the great Resurfix, and the innovation is on. This is a 2-minute AV.
Multi-application platform that treats more than 30 skin conditions and hair removal. With Stella M22, everyone can shine.
I instantly saw lightening of the skin. And with each treatment, when I would go into work, and I felt so good about myself. And so I
machine which can be upgraded with the IPL. You can also add a laser to it, a Q switch, and also the resurfax machine to it. Somehow the IPL technologies over time were overtaken by the laser technologies, but IPL technologies have a great way to go. Lots of functions with this particular machine, but there's a slight learning curve for pigmentation. It's great for acne, rosacea, any vascular lesions, and also for giving a nice bright look to the skin. But if you're doing isolated pigmented hypertension, hyperpigmentation lesions, then there is a slight learning curve and you'll have to do it rather gently. A great machine to go to with multiple functions. And if you have this, all you need is the HIFU and the MNRF, because those are the two things you don't have here. Apart from that, virtually you can upgrade it because you'll have the Q switch, you'll have the IPL, you'll have the laser in this. So that's how it is. And this is, of course, the AcuPulse. I have the UltraPulse, which is the higher version than this. Also does very well for scars. So you have the resurfax here, which can be fitted to this machine along with the AcuPulse, plus the whole lot of IPLs. And then you can add the Q switch to it also. Thank you.